Of the 81,000. Oh, yes. Sorry. Thank you for doing that. Of the 81, so the N is 81,000. Of that, 69% or 70% we were able to screen for smoking, of which we have positive risk at 11%, and intervention provided is 87%. Similarly for depression.
Okay. Are you able to show the slides, or am I just so clueless that I don't know how to see the slides?
You should be able to see it. I am sharing it.
Okay, so I'm just in the wrong screen. Okay, thank you.
Okay, no worries. All right, so for depression, of the 81,000, we have screened at 68% of those visits, and of those visits, we have positive risk at 6% of those visits, and we provided intervention at 92% of those visits, or 94. For our family planning, our risk screen was 67%, positive risk was at 28%, and intervention provided 70%. And finally, for the multivitamin and folic acid use, we screened at 67, almost 68% of the visits. We identified positive risk at almost 43% of those visits, and intervention provided was 64%. Any questions there? Okay. So all this work that has been going on with the implicit definitely is the expansion, the data analysis has been through some funding that we have been receiving. First one being the Pennsylvania Department of Health grant, which supports the implicit work in PA and supports the implicit network infrastructure. So we currently had the grant for 2020 to 2023, and we are working on submitting for extension for 2023 and 2023 to 2024. So more to come there later. In Minnesota, Implicit has been able to partner with the Minnesota Department of Health as well. And as previously reported, we have sites being implemented in Minnesota. Currently, we have, actually there should be cohort 3, and we are currently in cohort 3 and 3 emerging sites, and we currently have 2 sites that are sharing data. And finally, North Carolina had received a HRSA grant for 5 years. And so we are partnering with the Maternal Health Innovation Program and working on expanding implicit ICC in North Carolina. This collaboration consists of supporting sites with ICC implementation, providing coaching calls, and if you're wondering, like, why haven't an invoice been submitted to your site, it's because the Maternal Health Innovation Grant has been paying your membership dues for the last 2 years. All right. An exciting update that we have is, so the Implicit Toolkit has played a huge role for us in generating interest for sites across the US. And so we felt that it's time to update that now, the toolkit, and make it more current. And so we are able to, we're working with March of Dimes, partnering with them to do that. They are willing to support us for about $25,000 to update the literature review and add in additional items in the toolkit, such as the health equity section, adding the pediatric section, and updating the case studies. And so the PA team is currently working on that, and Dr. Stacy Bartlett from UPMC has taken the lead on doing the first round of edits, formatting and drafting the documents, and then the LC will be working on reviewing as well. And we're hoping that the final published toolkit would be coming sometime in July. It's not final yet, but we'll let you know. as it happens. All right. Any questions there? Okay. So with that said, Kendall, did you want to say a few words, or Stacy, did you want to just come in and talk a little bit about the Health Equity Committee and give updates there?
So I am not leader of the Health Equity Committee. Dr. Nargis Rocky is our chair, and then our fearless leader is Kendall Roseborough. But we have been making a lot of progress under those folks this year, I think. If anyone wants to join, our next meeting is in Thursday, April 13th at 10 o'clock. If anybody would like to join and talk to me or to Kendall about getting on this committee, but we're doing great things. So our goals this year are really focusing on community partnerships. So establishing what the principles of sort of engagement will be for community partnerships for all of our sites. And then as part of that, we're disseminating a survey to all of our sites to see what their current levels of engagement with community partners is, and what they would hope to have out of that. We're also working on some reframing and rebranding of implicit, just to make sure it accurately reflects the communities that we serve and hope to serve. So we're excuse me, we're going to be focusing on providing educational opportunities kind of through webinars and other sort of methods of distributing health equity content, and then journal club as well, and then our meetings to try to infuse as much health equity as we can into what we do. Sorry.
Yes, hi, like I said before, my name is Kendall Roseborough, and I co-lead the Health Equity Committee for the Implicit Network. Going into health equity data, we will have a breakout session to analyze individual site health equity data. Majority of the sites here should have a report. It's about 6 graphs that I created over the past week or so. All the data is phase 3 data, by the way, and the data is broken down by race and ethnicity. We can do by insurance, for example, insurance types, but today it's just race and ethnicity focused. The data does not include missing data, so that's important to note, because there is a lot of missing data, but it's not included in this report. So the first graph is ICC screening rate about well-child visits. So the total N that I use, which is also on the graph above the bars, is the total amount of well-child visits. So there were like 10 opportunities to have a well-child visit. Screening rate is if you did like how many you screen. So if there's 10 opportunities, only screen 7 of the time. So you have a 70% screening rate. Next graph is ICC screening rate when mom birthing person is present. So that just takes into account the opportunities to screen when the mom birth person is at the visit. Next graph is smoking intervention rate, and latter graphs are depression, contraception, multivitamin intervention rates. And all the ends there are just based on screenings of when the mom birth person had a positive risk. So the overall N is how many visits were screened where the mom birth person present was positive risk for smoking, depression, etc. So if there are 10 visits and the mom birth person, 5 of those people were positive for smoking, only intervened 4 of the 5 times, you have 80% screening rate. So keep that in mind. Some of the ends are like relatively small, depending on the race or ethnic group at your site. So be mindful of that. So the end might be a little bit inflated. Like, oh, I have 100%. That's great. Only had 1 opportunity. So hopefully it is great. So yeah, keep that in mind. This will just be a precursor for the later breakout session. So if anybody has any questions, feel free to talk to me or Mike. Mike is the master of data here, so maybe talk to him first. But I am also a resource if anybody has any questions or wants me to run a different R report for them. So yes, thank you all.
And just as a clarification, those graphs are the supplemental, not in the ICC data stapled packet.
Can we have a quick introduction here, please? Just want to make sure. Sorry.
Good morning, everyone. My name is Lena Kranek. I use she, her, hers pronouns. I'm from Minnesota. What else do you want me to do? I guess I work at the Minnesota Department of Health, and I'm the Women and Infant Health Supervisor in our maternal and child health section. So We fund some of the sites that are using implicit. We have 6 sites in Minnesota that we are implementing or have implemented implicit with. So we're excited to learn more and be here. Thanks, Maha.
Thanks, Lena. All right. Mike, I think this is your section. Sure. Sorry.
And Maha has been really great about trying to develop a new webinar on LGBTQ plus health, and so really excited about that. But I think it would really help because she's working with someone in Rochester to organize this, to hear what you all want to learn about or how to connect that to ICC, because we've had a little hard time like thinking of the best topic to build off of the last one we did. So I'd love to hear feedback on that so that we can build out that webinar for May.
Thank you, Scott.
Okay, I was asked to go through the health equity section in the report. So I think all of you should, in your packet, should have a report from your site. That might be helpful. And just to note, the report itself, we have a tool built that actually allows Anna and Carolyn, Kendall, and Maha to run ad hoc reports at any time. So if your site needs a report, you want to see something specific, please reach out. If you can't get a hold of them, you can email me as well. I'm happy to help. But the report is something that we've been working on for quite a number of years. We're on version 9 of the report now, and I think I want to say, was it around 2013 or so, I think we created the first report. It's basically just a block of computer code that runs, that gives us an automated readout of everything in REDCap, and it gives us a lot of ability to customize it by time frame or by site. So if you have any questions about that, I'll be here all day. I can show you examples of the report, what you can get out for your site. And just please reach out and we can get that for you. So just a couple of things about the report in terms of navigation. You'll notice on the first page of the report, now you have a printed copy, so it's not as active as if they email it to you, but the report is set up to generate an HTML document, and that's something that you can open with any browser, so you can open up Google Chrome or whatever. And the nice thing about it is the index that you see at the top, if you open it up on your computer in a browser, those are active links. So you can click on any one of those sections and immediately jump to that section of the report. So that makes navigation really, really helpful. You can, quickly just jump to the top of the report and then click on the section that you want to go to. So the reports themselves can get pretty long if you get all of the sections added. This index makes it a lot easier to find your way around. At the top of the index there, you'll see a section called Network ICC Summary Report. So that section is what I call kind of the core report. So every report that we generate will include that network section. And it basically just kind of gives you a quick summary of the screen rates, the risk rates, intervention rates for all 4 of the risks and so on. So that's kind of like the standard that comes. We can generate a report that just has that section, or you can have that plus, any other sections that you want to add, but that core will come with every report. And then right below that, I have an arrow there, the start of the health equity section. The health equity section is an optional section that can be added to a report. So, if you say, hey, Anna, I want, for my site, I want to see a health equity section, she can add that and just add that as a custom option. The health equity section looks at race, ethnicity, the insurance status of the mom birthing person, as well as the age, the maternal age as well. So any of those elements are broken down in terms of the screen rates, the risk and intervention rates for all 4 of the risk areas. So You can see that in the index on the screen. And then finally, the last example that I just included here is I ran a report for our family medicine residency site. So if you ask for the health equity report for your site, you will get both the network summary as well as your site summary. So that allows you to kind of do a comparative and say, hey, how are we doing relative to the network? So. Okay, so I wanted to just highlight a couple things in this report, how to interpret some of the information in here. The first thing I'll point out is there's a section in the report that's called the report information. I just wanted to mention that this is kind of important just in terms, particularly the date that the report was generated. The reason I say that is because the date the report is generated, our REDCap database, it's kind of like a living, breathing organism. So I can run a report today and I can run a report tomorrow and get different numbers because a site just uploaded, 80 visits or something. So just be aware of the fact that you could get a report and get another report a week later and the numbers may not match even for your site if you've just uploaded a ton of data. So it's kind of a constantly changing database. And so some folks get alarmed when they see different numbers we don't want folks to panic. And then down at the bottom of that report information section, if you do request a site report, you'll see that in that information section, it will list out the site that this report was generated for. So anyway, so that report information section is helpful. So the health equity report, again, this is the start of that section in the report. So you'll see it clearly denoted as whether it's the network or if it's specific for your site. I include the risk definitions. So what am I calling a smoking risk as an example? Basically, if they indicate that they're a current smoker. We've set these risk definitions for all of the depression, contraception, multivitamin, and smoking. So those are there just to help make sure folks are level set in terms of what that risk is defined or how the risk is defined. In that health equity section, the first part that is in there for race and ethnicity is looking at the screening rates split out by all of the race and ethnic categories that we include in our data collection. And this first table, the denominator is the number of well-child visits. So we have two ways of calculating the screening rate. One is with the denominator as well child visits, and the second table I'll show you here in a second is simply by if the mom is present at the visit. We split it out both ways because not every site can conclusively determine from their data whether mom was present at the encounter or not. So the tables, the columns here show you the number of what we call dyads. This would be the mom birthing person / child, the total number of well-child visits, the total number of well-child visits where all ICC was done. That just simply means all 4 of the risks were screened, or a partial ICC, meaning that at least one of the risk screens were done. And then we calculate that completion rate on the far right-hand column. The second table there, again, breaks it down by all of the race and ethnic groups here. But this is splitting it out by the denominator here is just simply if the mom or birthing person is present. And so we're excluding those where we don't know if the mom birthing person is present, or if they are designated as not being at the visit. The other thing I'll quickly mention too, race and ethnicity, you can select multiple options. So there may be mom birthing persons that are in multiple rows here because of the race and ethnic selections that are made. So if you have somebody that's classified as white and Hispanic, they would show up in both areas. Okay, so in that health equity section, there are a number of these kind of weird looking, these are actually called caterpillar plots. You basically, on the horizontal axis on the bottom, you have all of the race and ethnic groups split out for your site, or if you're looking at the network report for the network. And essentially the center line in each of those are the overall rate for all of your combined race and ethnic categories. And then there's 3 graphs here. So for this one, it's the lower graph that has the blue color is the screening rates with the well child visits as a denominator. The light blue is the screening rate for mom present, or the mom birthing person present. And then the purple one on the top is the rate or proportion of moms present at the well child visit. Each of the points represents the rate for each one of the race and ethnic groups. And then there's a 95% confidence interval that's constructed. And we recently added the little numerical notations for the upper and lower confidence interval limits, as well as the rate for each one of those, just to make it a little easier to quickly look at the graph and get those rates right off of the image. A couple things, I did put some notes over here on the side, just in terms of helping to interpret that. If the confidence interval doesn't include that center line, you can then conclude that, oh, it looks like statistically, it looks like that rate is higher or lower for that particular race and ethnic group. That rate is statistically higher or lower than the overall rate. Or if the confidence intervals do not overlap, you would be able to say, oh, perhaps the Hispanic group is higher or lower than the white group, as an example. The other thing I'll note is some of the points you'll see on the far end there's a couple of the points that are hollow circles. Anytime we have a denominator less than 30, I don't include a confidence interval for those because they tend to get really wide at that point. And anytime you have a rate of 100% or 0%, you technically, you really can't calculate a confidence interval. So those are also noted with those hollow circles. Trying to think if there's anything else. Any quick questions on the graphs themselves?
That the network data that you have on the screen?
This is our this is Lancaster. Yeah, I'm using Lancaster kind of as an example for our, just to be able to interpret our site. The network confidence intervals get really, really tiny because the ends are really large in those groups. The report then goes into each of the 4 risk areas. And again, the data are presented in a very similar format. So, for smoking, depression, contraception, once you kind of learn how to interpret it, you can kind of go through all of them, and everything is the same. So this is the example here for smoking. You'll see that we include for each of the race and ethnic categories, we include the total well child visits, how many well child visits were they screened, the risk positive, and then the percent of well child visits where the risk was positive. Was there documentation of some sort of intervention? The percent int D column, and again, that's in the text up here if you forget what those columns represent. The percent int D column is essentially the percentage of interventions provided when the intervention was documented. The percent int R over on the right, that is including the missing. If a mom was identified at risk, but the intervention was not documented, there's no documentation of an intervention, whether it was done or not. We then assume on that far right column that the intervention was not done. And so that's just simply, so you'll see those percentages are usually a little lower if you have missing interventions. So we calculate it both ways. So internally, whatever rate makes the most sense for you, it's there and it's available. And then similarly, we plot out for all of the risk areas. We have the purple graph on the bottom is the actual risk rate for each of the race and ethnic groups. So if I'm looking at the Lancaster data here, it looks like statistically our Asian folks that identify as Asian, statistically, we have a lower smoking rate in that particular group compared to the overall rate for our site. And it looks like in the white group on the far right, statistically 14.4%, statistically, that's a higher smoking rate, screen positive for smoking than the overall rate of 10.6%. The blue graph in the middle there is that rate where we're only including in the denominator where the intervention was documented, either yes or no was an intervention done. And then finally, the light blue graph on the top is the denominator that includes all individuals at risk. So if the intervention wasn't documented, it's considered not done. But the interpretation is the same. The confidence intervals are there. If you get the health equity report for your site, what I did is I just kind of cut out a piece from the network report for the smoking risk rate, and I also included our site data, just so you can see, if you want to compare, gee, how are we doing? What's our risk rate look like for our site versus the network? So you can see, again, it gives you the ability to compare, kind of see how you're doing relative to the network. So the health equity report, as I mentioned earlier, it's an additional component of the report that any of folks up here can add for you. Just please let them know. The other thing I'll point out is the reports can be requested based on timeframes. So you could request a report for your site based upon the month and year of the well child visit. So if you want to look at, I have an example up here. If you want to look at essentially the last 6 months and say, hey, I want to report a health equity report for the last 6 months of well child visits, or by birth cohort. You might want to look at all the well child visits for babies born in 2022, and you could get that as well. And then the network and site summary, the report just basically loops through all those sections, so the sections will be the same for the network as well as your site, and give you all of that output. The other thing that might be helpful, there's another section of the report that you can request that adds in phase 3, just generic phase 3 demographics. I included a table from that section of the report as well. This just gives you an overall race and ethnicity summary for all of your dyads, your mom birthing person / child dyads. So that might be helpful too, to get that included in the report, because that at least gives you a summary or a synopsis of what your population looks like. The other thing that's included in that part of the report is this kind of funky looking graph that basically shows you for all of the maternal demographics, what elements are missing from your site. These demographics, we tend to have a number of missing elements. So this comes out of our site report, and it just shows how the Lancaster residency program, how that data compares with the network. And in terms of the education, month and year of the infant birth, insurance, marital status, maternal age, and race ethnicity. So it at least gives you a sense of, race ethnicity, we have complete data on about 83%. Our site has complete data on about 83% of our moms and birthing persons. So I'll be here the rest of the day. So if you have specific questions, I'll be happy to look at your site report, help you interpret the data, go through. I have my laptop here. I can run a report and, do some more custom things if you want to see some additional information, but I'm here to help. So, let me know, and we'll be happy to help you out.
I did want to just point out one thing. The R reports that you have stapled together, those are just your site specific report. I was trying to save some trees, so I did not print out the whole network data, but we can send you an electronic copy of that just so everybody's aware.
Mike, can you give us some guidance in interpreting some of these equity graphs? Because with the statistical ranges that are there, it's going to be really hard for any site. I mean, I'm looking at ours and I haven't looked at everybody's, but these confidence intervals are going to be overlapping. So for a network that's thinking about how to guide their workflows based on this data, and you're looking to say our intervention rate is 5% different between our white population or Hispanic population or Black population, even though those confidence intervals show that those are statistically the same. What is your guidance in terms of looking at, like, are those confidence intervals really based on our ends here and the number of things that we're comparing, the number of, or should we really be focused on trying to make those rates equal, or improved across the board as sort of the next step of what to do with this?
Yeah, I mean, that's a great question. You're right. And it's particularly some of the smaller sites as well. They're, like, I mean, I know like our residency program, we have a much higher volume per month in terms of child visits. So we can take a shorter time frame and look at it, and we can start to see some of that more of that separation, but smaller sites won't be able to do that. And certainly at a network level, like I was actually on the train on the way down here, I was again looking through some of the sections at the overall network level. And there are clearly some differences in smoking rates and depression rates across the various race and ethnic categories. And insurance, if you look at the medical assistance population, much higher rates of depression, much higher rates of smoking, and the confidence intervals clearly separate and are above the line or below the line. So, so yes, absolutely. If you're a smaller site, if you really want more of an inferential, realistic approach, you're going to have to take a longer time frame that gives you a larger end to say, how are we really doing across these groups, and to be able to compare. And that may mean that you want to make sure you have at least 12 months of screening data, or maybe even 18 months or more, depending on if you're a really small site. But I think going any less than that to say, oh, how did we do the last 3 months? I'm not sure that there's a lot of value, because those confidence intervals are going to be so large that you're really not going to be able to draw any realistic statistical conclusions. But certainly at a network level, we have a large enough N of child visits coming in, even, in a 12-month period or even a 6-month period, that I think, if the network says, hey, here's something we want to look at, we could certainly do that. Now, the other thing that I see in the data too is, if you look across sites, there's a very different race and ethnic profile across the sites. And so I think teasing that out is helpful too. I know in the Lancaster site, particularly the residency, we have a very large Hispanic population. But there are other sites that I see that have, almost zero. And so I think teasing out some of those differences would be helpful too, to, parse that out.
Any other questions? Including online, if you have any questions.
And I teach in an MPH program down at UNC in their online program. And one of the things we talk to our students a lot about is, there's this perception that we're always chasing a p-value. We're chasing some p-value to find statistical significance. And while that's helpful sometimes, gee, the confidence interval doesn't overlap or whatever. And while that's helpful, I think from a mathematical standpoint, some of it comes down to, what are the practical realities that we see in our clinics every day that make a difference? And so, balancing that, kind of the clinically significant and the statistically significant, I think, there are some things to tease out there as well, that it's not always just chasing the p-value or the 95% confidence interval. So.
And it seems like it's been very focused on like visit level ability to screen and intervene, which totally makes sense with the effort to expand and standardize screening. When you're thinking about sort of the equity perspective, have you ever tried to run a report looking at sort of the dyad level? So seeing like how many times in that 2 years a dyad is able to make it to a well visit, is able to get screened at a well visit, is able to have a conversation about these risks, because that might show a slightly different pattern than what you see when you just look at what happens by the time somebody makes it in the door.
We have we have like, for example, in the report, one of the other sections you can actually get out is a behavior change section. And so we look at that in particular 2 ways. One, if they show up at an encounter and they're at risk, what is the next encounter? What happens at that next encounter? Now, that particular report, we don't, as a standard, we don't break it out by race and ethnicity, because some of the ends get really small in some of those categories. But that certainly could be something we add. And then we also look at it within the dyad. So we look and say, oh, were they at risk at any point during that that first period of that 2 years that we're tracking? And then at any point, did they then screen negative at a subsequent encounter? So we do some of that in other sections of the report, just not particularly this one.
I think that's a great suggestion, and it sounds like it's a new project. I mean, we used to look at the visit level all the time, and now we do look at the dyad across, like for that dyad across that 2-year span. What's the rate that they were screened at all, or how many times were they screened?
Right,
And that and we could look at the behavior change, but you're right that certainly this is families that come in twice in that 2-year period may have been screened 100% of the time, but only twice. Families that come in 10 times may have been screened 50% of the time, but have been screened 5 times or offered interventions. And so from a health equity perspective, are those 2 things the same or different, and how do we look at that? So it just, again, it's a year ago we were talking about doing this, and now we actually have built and have the data. And a year ago, our demographics were pretty poor, and we worked on improving those so that we could have this, that's more accurately reflected for each site, so we have better data. So I mean, I just think, we've really been progressing, but it sounds like by next spring, Emily Gregory will look at this report of, dyads and interventions, by family, broken down by race and ethnicity, and we'll have a better sense for the overall impact of this model. In a new section of the R report.
Right. Yeah, I just looked at this not too long ago. Across birth cohorts, across an entire completed 2-year cycle, on average, we're about, our dyads will have about 4 to 4.5 encounters. So, and most of them are in the first year. That's the average across the network. Now, obviously we have some, we have some that are 10, 11, 12 or whatever, across the 2-year period, but on average, it's about 4, 4.5. So.
Those are any encounters.
Child
visits.
Yes.
Where ICC was performed,
was or was not done. Doesn't matter
done.
whether it was done or not, but how many encounters get into the REDCap database? Yeah.
It's a really important statistic. Of course, like people can move into or move out of.
Right. Exactly.
So
we have some of that attrition, coming in
piece,
and out. Right.
We don't get 10 at bats for every family.
Right.
Any other questions? And again, we will have time during the breakout session. If people really want to dive into this and ask questions of Mike, we will have that time later this afternoon. Oh, sorry, hold on.
Hi, really interesting report. Like I said, I'm new, so it's really cool to see this data outlined. And I went for my MPH in Epi and Biostat, so just looking at the data is really cool. Just out of curiosity, what program did you use to like create these plots? Okay, cool. I use SAS, so just wondering. Thank you.
What was the answer?
Our report, R.
No, the program is our report.
It's R.
R is the thing that makes the R report. Got it.
Any other questions?
All right, good morning. So again, my name is Brianna Moyer, and I am one of the members of the Data Review Committee, also with Anna Federoff. So we're just going to talk a little bit about the Data Review Committee and some of the things that we've been working on. Our meetings are always the second Wednesday of every month from 5 to 6:30. So anyone who's interested, we would welcome you to join us. So some of the things we've been looking at with the Data Review Committee specifically has been improving family planning intervention rates. And as everyone knows, we've been doing a kind of network-wide QI project or a PDSA cycle around this, which we're going to talk about in a little bit more detail. We've also been collaborating with the Health Equity Committee on health equity data, working to assist in increasing network publications, and then also analyzing the fourth trimester data and thinking about how we may want to adjust some of our questions and some of the things we're asking as we're thinking about moving the fourth trimester project out of the pilot stage into the phase 1. And so in terms of the current projects that we're going to talk about a little bit more detail today is our contraception to family planning quality improvement project, and then also some data updates as it relates to ICC data. So in terms of data updates, there's a couple of things we've been talking about in regards to the ICC data that we do want to change to get some different data or some more specific data. And as we talk about this, just to give everybody heads up, with some of these changes, that will mean that there will be a phase 4 of ICC coming. Not today.
Sorry, Mike.
Sorry, Mike. Yes. We are thinking that the phase 4 will probably come into effect after the fall meeting. So there will be a lot more specifics and details coming in the future, but just wanted to put that on everybody's radar that that will be coming. And some of the things that we're looking at updating. So the first is in regards to smoking and just how we ask that question. And we want to change the question from being a smoking status to smoking and vaping status. So hoping to be more inclusive and make sure that we're not missing people who may not be smoking cigarettes, but are vaping on a regular basis. And so that is going to be one change. The second change is related to marital status. So the marital status question, as it currently stands, asks very specifically if people are legally married versus living with a partner versus single. And we were thinking about, what are we really just trying to get at with this question? What is important and what does that mean for the patient and their outcomes? And we realized that this question can make some patients feel uncomfortable if they don't know where they fall or how they categorize things. But really the heart of the question is, do these parents or does this birthing person have a primary support person? So do they have support? And if they do have support, do they have support in the home with them? Do they have support in another location? And so what we're proposing is that we'll change the question from marital status to, do you have a primary support person? And then the question options will be yes in the home, yes out of the home, or no. And we're hoping that this will just give us a little bit more information into kind of the support system without being an uncomfortable question for the patient or the provider to answer, or also to make it less confusing, because I think sometimes patients just don't know how they fall into those categories. So these are some of the changes that will be coming with phase 4, in addition to, along with the family planning quality improvement project, we've been talking about getting rid of the tier levels for contraception. And so that's something Anna's going to talk about in a little bit more detail.
Questions?
I posted my question on the chat, but I'm wondering, will there be any cues or explanations to help folks understand what you're driving at with the question of primary support person?
So that's a great question. We've
I
definitely
was
been
wondering that too, because people will say, well, yeah, my mom helps me. Is that what we want to know, or what are we trying to get?
Yeah, we have been talking about that. This is again one of the questions that will not change until a phase 4. So this is a great place to come and join the data committee to discuss this information, because the more people we have talking about this, the better to really understand how we can best approach this question, because it's already been several discussions, but we would love to hear from other people how we think would best present this to the patient.
And I will say we had a lot of discussion about whether or not we should have the patient identify who that person is. So should they identify it as a partner or a spouse or a mother or a sister? And I think we had kind of concluded that we wanted to make it as simple as possible. And what we were really looking at is, did they identify that they had somebody who was supporting them? So really coming from a patient perspective, does the patient feel like they have support? And moving away from, like with the marital status question, we were really asking about like, did they have a legal spouse or did they have a partner? So I think it is a change in what we're looking at. And like Anna said, definitely open to further discussion about that, because we had debated a lot about how specific we need to be, and if we need to know particularly who that person is or not.
So this primary support person really could be sister who lives next door, or mother who lives in house with the person. It's not just about significant other, committed partner, or spouse along those lines. Is that what you're
Yes.
all saying?
Yes, absolutely. Yep. So it could be any person that the birthing person identifies as a primary support.
Mario, did you have a question?
Certainly agree with changing the marital status question. But as far as I know, other than sort of reporting our demographics and understanding sort of who our population is in our ICC network, I don't know that we've done a whole lot of correlations with this demographic in terms of marital status and any outcomes like screening rate or interventions or, whatever. And so in one way, it might just sort of describe our population a little bit better. But in another way, we could actually do this. I mean, we collect a lot of data. We don't have the capacity to analyze all of that in every way. And some of these things may not be meaningful. But this one could be. And so we may want to actually do something more with this, like we're doing with the demographics about race and ethnicity, and understanding how our model works for people who do or don't have support, or maybe sort of recategorize that as not as a separate risk factor, but like we could also look at that as a risk, just like insurance type or anything else. So potentially this gives us the chance to do something with it. And so then I think then the question is, does identifying who that person is matter? Or are you really just going to be looking at the yes, no, do you have support or not have support? And the other piece of this is that sometimes the maternal demographics are collected in an automated way, or, like we may not be using those as sort of like an assessment. We're just sort of checking the boxes to like understand that demographic. This is one where I think if you're actually asking this question, you're saying, and this may be Josh's point too. Does the patient understand what you're asking? And if they say at that point in time that they don't have support, should that prompt an like, what are we doing?
Yeah, I was worried about the same thing. If the person really says, oh my God, I have no support, I guess I would be anxious if they can't come up with a single person. And not that I'm saying we're asking that, but if they truly say, no, I have no support, that means there's not a sister, neighbor, whomever that they can count on. And then I think, do we just collect that and say, oh, look at that, you didn't have any support, or what do we do?
And then my other thought is,
I mean, after, because we'll be looking at it after the fact.
is looking at what level of support that is. And I know that's a whole nother iteration further down, but somebody could live with a spouse partner and have absolutely no support from them. Or they could live with
Yes,
their
also
mother in a
true.
very antagonistic relationship. And so having somebody that is their support may vary. Again, we're not ready to do that, but I think as we start thinking about what question we're asking, how do we use that data?
I also worry that the more a question requires refinement or explanation or examples, the more cumbersome it becomes to offer to a person and expect them to quickly move through giving us the information we hope to get.
So I'm not in the network, but I have lots of thoughts about this question. This is Sarah Verbeest. First of all, I think it's really important to change up the marital status question, because we've definitely heard from birthing people that that's just can feel blaming, shaming, especially in the South. So, and who is the support person is really key. And if they say no, what do you do? Right? Because we're with so many things, if you're screening and it's no, and you can't offer something, what might they do? I would suggest, since you've got time before phase 4, you focus group this, you listen, get some circles of birthing people and talk to them about it.
It's a good idea.
And talk with some community groups about what would be a good response, because I do think this is really important if we're thinking about isolation, depression, substance, all the things that we know are causing harm. We would, if someone said no, we'd want to offer something, but what would that be? And then this also does make me think about screening for interpersonal violence, to your point. Like, what if there's things happening? We know that that's an increase. We've seen that homicide's a maternal mortality risk. So this is juicy. We volunteer to help.
So I would like to interject, I do ask regularly, because again, I understand everybody screens this differently, whether it's verbally or not, but in my everyday practice, I ask, like, do you feel like you have good support taking care of X patient? Do you have people in? So I explain it a fair bit, and they get used to that, what that means. But as for if they don't have support, we have access to virtual mom support groups that we referred them to, and say, hey, here's this, you can, talk to the moms. This is hard, I know, and, try to make some at least connections that way.
That was along my thoughts too. When you screen negative, what are your supports? And when we look at community collaboration and health equity, are we partnering with doula groups? Can we offer a postpartum doula if they screen, positive, essentially negative for any kind of support? So really that community collaboration may fit really well as we're doing. If we look at focus groups for this, of what are the next steps, because we know people don't screen for things that they feel like they can't do anything about it.
I'm going to give the mic to Amy real quick. So this is
But
leaning
this
more
question is in
towards,
the demographics, right?
I was just going to say, this is leaning more towards, this is no longer a demographic. This is an intervention.
Right.
Which is
Well,
not a bad
I
thing.
think
And
to Mario's point, we were sort of collecting it as we do, because we love collecting data. We're data hoarders. So now if we're going to change it and then make it something really actionable, then that's that's something else. Back to you.
so let me add my plug to please come join the data committee and have a further discussion about this before phase 4.
You don't have to be a data expert.
This sounds like it's just a big plug to get people on the data committee, and it's working. So kudos.
This is also, just to put it in context, this is an ICC demographic. And so the context is a pediatric well child visit, and this is screening, we're doing interventions for a mom or birth parent that's present at that visit. So, when we talk about they might be at risk for depression, the model is actually to screen them for depression 100% of the time. That is sort of the model. And so, and I just want to be careful, because I think Amy's point is that maybe this is actually a different risk factor. But this whole ICC model is sort of set up to be a rapid, feasible, implementable, scalable model that can be done in pediatric offices that are taking care of children. And we're talking about a lot of things that are sort of fit our family medicine model, for instance. We're an obstetrical model where we're talking about doula support and parental support. And, so I just want to be careful that we aren't moving too far into away from the model that we've been trying to pilot and test and study and scale for the last 10 years.
I will say that this would be changed in the fourth trimester as well. We would not be asking marital status anymore in the fourth trimester. So maybe some of those taught resources would be more applicable to the fourth trimester, but great point. Hold on. Sorry, they can't hear you online unless you have the mic.
So one thing, part of this idea did come, so for those of you who do fourth trimester at UPMC in our early postpartum, we ask, how are you sleeping? And then we also ask, do you have a support system at home? And that is something we ask in our postpartum visits. And so that's when someone would be like, yeah, my mom or my in-law or my spouse. That's obviously just kind of a part of the conversation and used for our physicians to then provide kind of tools and like what they think their patient may need. So a lot of these conversations do seem to kind of lean more into a fourth trimester intervention, and maybe it looks a little different than ICC than fourth trimester, but just to give some context. And then we did have one question or comment in the chat that is, this is a great idea for many of our families. However, it does not resonate with our reportable demographics data, as we need to report this for measures. So I think that's an important issue to address, that sometimes if you're collecting data for someone, they might need you to say maternal demographics, like whether they're married or not, whether or not that's a question we want to ask. So I don't know if anyone has any thoughts on that.
So that was something that we did look into and do some research, and we did speak with our Pennsylvania Department of Health partners about changing this. And there are other academic studies and where they look at a support person and not marital status. And then there are a lot of them where they just don't have marital status at all.
Can you comment on that? Because we had to, the people that we are reporting to are the departments of health.
Honestly, that's one of the things that we're doing internally, is trying to make sure that the data we're collecting is utilized for something. Like, what's the purpose of the data? But we need the data to understand where there's disparities. Like it's like this continuous cycle. So it's very interesting listening to this conversation, and I'm spinning my wheels trying to figure out, in terms of all our programs and all the programs that I'm responsible for, how this question, the data we're collecting, how we're using this particular point, and not wanting to like have a thing that then can't be used with other data points. But I don't think we're actually using this bureau-wide, at least for Title V, as a reportable measure for our application or reports. We're just going through that now, and we have age, we have like male, female, like how many pregnant mothers is one, insurance, but not marital status. So I think it's a good idea to, because it's more about what support a person is getting before, during, and after birth.
But that's not also not a demographic.
So do we not need it in the demographics then? Is that what I'm hearing?
We need it per our grant agreement.
Oh, we do. We do need it.
But at a broader level, this is something I want to take back to leadership, because we are trying to figure out how to make the data we're asking for make more sense. So as we're establishing additional grant agreements or revising things, we don't want to just be asking for things just to be asking for it, just data for the sake of data, because we like data too, but what are we doing with it? So I think it's a really valuable point to be discussing. If it changes, like in terms of the grant agreement, if you change it, this will still be fine. Like, don't worry about it in terms of how it's being collected, or it'll be fine on our end. But how you'll use that information moving forward, it is a really important thing to know what you're going to do with that.
And then Alina, did you want to add to that? Because you're like representing the Minnesota department and this is Minnesota question, so.
I totally agree. Like with Title V, I imagine we don't use much with marital status. I feel like it's just it's probably based in birth and death certificates and how we used to collect data. And we haven't really updated how we're nationally like watching these metrics, and we're just collecting data to collect it. So now I'm thinking too, I'm like, oh, now I need to go talk to RFEs and see what are we doing. But I work in the maternal mortality space, and that's the thing that for this would be a huge important change. But now going into intervention, right? Of like, now I want to know, like, do you have that support person? So I recognize like if we're talking about the data, but also like I'm thinking of what's the intervention of why we're asking that question. So I really appreciate this conversation. It's really making us think of why we're asking these questions and how are they supporting the people that we're here to support instead of just not.
So this may be coming out of context because I'm brand new to all of this, but I thought I would at least point this out. I think that when we're thinking about the value of a question that could be used for risk stratification, it's also we're thinking far in the future. The more we add, as somebody pointed out earlier, the more questions we add to a questionnaire or a screening, the more difficult it becomes to complete, the less patient-centric it becomes. There is a role for highly risk stratifying pieces of information that then branch out to other portions of a screening questionnaire. Not that, I don't think we're at that phase, obviously, but just to think about that in the far distant future, if we have points of data that allow us to risk stratify, we can then cascade out other questions to target more specific associated risks with that particular population. Again, possibly out of context, but I thought I'd at least mention it.
All right, any other questions before Anna moves on? Okay, perfect.
Awesome. Thank you very much, everyone. That's really helpful information for us as the data committee. And again, I invite people to join this discussion on the second Wednesday of every month. So we're going to talk about this year's PDSA. As a reminder, last year's PDSA was our maternal demographics, and it's something we still want to be looking at. Just we don't want to say just because we focused on that last year, we're not looking at it anymore. Obviously, we've talked about the health equity section, how it's really important to collect those. So we'll still be monitoring that. But this year, our PDSA is moving from contraception to family planning focus. So just as a reminder of what our PDSA timeline looks like, this was introduced during the fall meeting last year, and we kind of set some goals and metrics. The first data collection period is considered this quarter, so January to March. We gave baseline data from October to December. And then at this meeting, we're going to talk about some implementation plan ideas and the network changes that we would like sites to do, and then optional changes and resources that we have for this. And then we'll have 2 more data collection time periods, and we'll disseminate the results at the fall meeting coming up. So as a reminder, why we are focusing on this as a PDSA, we really want to make sure we're being intentional about person-centered contraception counseling and avoiding any contraception coercion. So like Brianna said, we're removing the tier language. And we did recently just have an amazing webinar that was moving from contraception coercion to, or reproductive coercion to, reproductive justice. Thank you. And we do have that recorded, so we'll make sure that everyone has access to that. That was a very comprehensive webinar. We also have noticed that we have low intervention numbers for this risk over the last year, and we're really want to make sure we're helping sites have the best tools to have these discussions and to provide interventions. And that we've also noticed when talking to some of these sites, there's a lack of knowledge around some of our intervention options. If anyone knows their interventions offhand, there is a very long one for contraception that talks about providing educational material, reviewing family planning, and checking on current method satisfaction. That current method satisfaction tends to get left off for sites unless it's clicked on. So there were a lot of people that didn't know that that was an option, that just checking in did count as an intervention. So again, these are kind of our data updates. So removing the tier language, this is more provider facing. We are not changing how the contraception types are listed. We are literally just removing tier 1, tier 2 from the wording, just to kind of not induce that, you know, we're looking for you to provide a certain tier. We want, again, that conversation to be with the patient and centered around their wants and needs and what's best for them. The intervention split. So this is our long intervention that for a lot of the sites, if you're using the National Epic build, unless you click on this as an option, you cannot see the reviewed current method satisfaction part. So we are proposing that sites split this intervention. So basically making it into 2. You can see that below. And part of this is to kind of bring more awareness to that intervention. As far as data purposes, they will still be counted as one intervention on the back end, but this way our providers are really understanding what their intervention options are. We are also, to try to be just inclusive and make sure we're being holistic, that we're adding emergency contraception as a method choice, and this will be added to the option that has barrier, withdrawal, sponge, spermicide. That will be added to that option. So all of these changes we are hoping to make in the near future before that phase 4, because these are things that don't affect our data validity, but they provide, I think, what we're looking for with the PDSA. But these are things that I will make sure to reach out to each site individually to really work on them with, and knowing that this is a process. We know IT at every site is over-asked and understaffed. So knowing that this will be a process, but that you will have resources and help with this. So this was data we showed at the fall meeting. So our risk positive from June 2021 to July 2022 was 28.3%. And then a network average was 48.8% of an intervention provided. The goal listed there is the goal that our Pennsylvania sites have with our work statement with the Pennsylvania Department of Health grant. So you can see that that is, as a network, we are definitely under that, and we would like to bring it up closer to that. This graph just shows the breakdown of the sites that have data from that time period and what their interventions look like. So the gray is no intervention was provided, and it was documented that no intervention was provided. Some exciting news: August 2022 to January 2023, we are up 10%. So we now have a positive intervention rate of 59.8%. So I think that's awesome, with just the fact that we've been having these conversations and reaching out to sites and sending them their data, that we've seen an increase already. So we're hoping to continue that trend as we provide the implementation plans. So some of these implementation plans have come from sites who have already kind of set up what their plan is, and they've sent me that information. I'll be reaching out to all sites to have that information. Again, as a reminder, we did do a pre-survey, and the majority of sites have had responses from that survey. I will be reaching out to sites that we don't have any responses yet, because I think it just helps us understand where the challenges are at that site. and helps guide that site-specific plans. And the goal is, after the implementation of those plans, is to send out a similar survey to check the knowledge after we've done this. So from the information from surveys and sites that we've talked about, observing well child visits that have ICC to just identify where there are areas of improvement, and ideally observing it more as I'm observing a well child visit and not letting people know that you're actually more interested in the ICC portion of what's happening. So we don't have inflated use of ICC that wouldn't normally be used. Putting ICC reminders on appointment schedules in the EHR, having more education on the intervention options, knowing that checking on current method satisfaction is an intervention, providing additional patient educational resources. I did bring some of our educational resources that we have currently, but we would be interested in looking, have sites found other resources that would be helpful that they think to share with the network, to share with their patients. And then also providing an educational component. So this is just an optional tool, but this really hits home our patient-centered contraception counseling. So we're looking at focusing on the PATH method, and we're going to be putting together a PATH like educational presentation that either I can do at your site, or you can do it at your site as well. And then we actually recently were doing this at all of the coordinators in Pennsylvania. All of them are recording video examples of ICC and fourth trimester videos and fourth trimester visits, just to get a better, for when sites are new or you have new residents, they can kind of see what a workflow looks like doing ICC or fourth trimester in a visit. And we recently did one that was an ICC visit that focused on that PATH intervention, having that conversation with your very own Dr. Moyer and Dr. Cantu. So that will be another resource that is available. I'm gonna give the mic to Brianna. So Brianna is going to talk about the PATH framework.
So as Anna mentioned, the PATH framework is something that we're suggesting as a potential educational tool for providers. And this comes from the Family Planning National Training Center. And the mnemonic PATH stands for Parenting, Pregnancy Attitudes, Timing, and How Important. And so this is a model of how to kind of approach the conversation about family planning that's more patient-centered. And so you can see there on the slide, they kind of list the questions there, but asking first off, if the patient feels that they may like to have children or more children at some point. If so, asking about the timing. So when do you think that might be? And then finally asking about how important it is to that individual to prevent pregnancy. And so this provides some framework for that conversation where you're understanding where the patient's coming from and what their future plans may be in terms of children, and then how important it is for them to discuss whether or not they want a method to prevent pregnancy. And this is a handout that also comes from the Family Planning National Training Center that just gives some additional kind of scripting for how to have these conversations. So again, starting first with inquiring about reproductive goals and needs, and having a sense of, if the patient is interested in pregnancy or pregnancy prevention, and then also just some questions to ask about understanding their perception or their understanding of family planning methods that are out there, and also how to kind of facilitate when the patient may have concerns or questions that they bring up. I think the facilitation skills are helpful in the sense that they really focus on validating the patient's concerns. And if they say, well, I've heard that Nexplanons make you gain weight, saying, yes, that's good that you heard that, and let me tell you this. So really validating and being empathetic about the concern, and then also providing additional information in alignment with the patient's goals. So this is a really helpful handout, and the path model is on the Family Planning National Training Center website. They have a lot of really good resources for providers. So this is something that we're suggesting can be used for helping to train providers on how to do this as you think about what your own site might do for this PDSA cycle.
Thank you. So does anyone have any questions about any of that information?
So if you just look up the path model, but it's the Family Planning National Training Center.
And it will be included when I put together the educational presentation. We'll make sure to include those resources as well. Any questions?
Any virtual questions? All right. What time is it? I just need to double check something.
And the options for contraceptive interventions, those would be part of phase 4, like are they going to change before then, or they would change with phase 4?
So the question was just asked about if the contraception options would be a phase 4 change or before. I've had a discussion with Mike and we've kind of talked about both possibilities. I feel strongly that I would like to try to have these changes happen before the phase 4 because they're not things that would affect the data coming in. But understanding that for some sites, it just may not be feasible and until that phase 4 rollout happens, but really wanting to, you know, work with sites to try to make that happen. Any other questions?
So if you could summarize in 2 to 4 points, what would you want offices to do now to make this work? Offices or health centers, like before phase 4?
As far as the PDSA?
Well, this is beyond that. 3 takeaways from, you know what I mean? Like in terms of practice.
So 3 takeaways. We would love the removal of tier language, splitting the intervention, and adding emergency contraception. If that is not possible, as of like right now, those data changes, because for sites using an EHR that requires changes within your EHR, I think the one big thing would be if your site hasn't done a pre-survey, to do a survey to make sure we understand where some gaps may be so that we can use that survey to tailor some intervention or some quality improvement at that site. And then 2 would be utilizing some education around patient-centered contraception counseling. So if that's the PATH method or if there's a different method that you'd rather have. And I know that was not 2 to 4 words. Yes, yes. These are the required or what we're going to have as standard for the network moving forward. But then the other implementation plan ideas, these are not required. These are just suggestions. The PATH education is a suggestion. But those 3 things we really want to address.
Yeah, I just wanted to point out, we're always at high demand for an Epic analyst to like change your build and all that stuff. It takes a long time. I will say that in the past year, we did, doesn't require a new build to go in and edit something that already exists in a build. And that can be a quick thing. And so we had somebody remove like literally where it said tier 1, tier 2, tier 3. And then also the option that says provide education materials on birth spacing and or family planning options or reviewed current method satisfaction. We put reviewed current method satisfaction first so that you could see that because it is a long option. And so that didn't change the build or the background or the smart data element, and it didn't change the reporting. It just changed what the provider sees. And so those are easy things to do without having a, like a big process. And then I think the doing path or education, can happen without absent of your Epic build. And then the survey, which I think Anna and Kendall already have one, built into RedCap or whatever, that can be done at a residency site. I think that's how you can sort of build some buy-in for the fact that we need to do some PDSA or, QI around this.
And I will just say as a side note, the survey is also just helpful in understanding your site's knowledge around ICC in general. It is focused on contraception risk and interventions, but there are questions there that really can help you understand how ICC is perceived at your site.
And just to clarify, if we don't have Epic, do we still need to do the intervention split? Because I just looked at a test patient and ours is very easy to read as it currently stands.
Yeah, if yours is easy to read and I can reach out and chat with you about that, then I think the biggest thing with the intervention split is, or as Mario said, their site moved the current method satisfaction to the front, is just making sure that we're highlighting that as an intervention option. Does Carolyn have one? Okay. Any other questions or comments?
Okay, if nothing else, let's go into break, right?
Yeah.
We're ahead of time, so I'll give you 15 minutes for break. All right, you may break.
What time should they be back?
What time is it?
I don't know.
Let's be back by 10:50.
So we will resume at 10:50. We're going to get started again in about a minute.
Oh, no, you are totally fine. I really remember this in the draft on the computer, so please take up the I encourage it.
Like either you're about it.
Yeah, I will like, I'm going to consider like.
Okay, if everyone wants to find their seats, we're going to go ahead and get started. Our next section is going to be an update from the Scholarly Activity Committee.
Hey, guys. Good morning again. I'm glad to see everybody here as we're, before we talk about the Scholarly Activity Committee, I just wanted to once again welcome everybody to be in Philadelphia. As far as I know, this is the first time the spring meeting has not been in Lancaster. You know, it seems like that's where it was forever. And the last 3 years, starting with March of 2020, where we pivoted from an in-person meeting to a virtual meeting, we've been virtual. So really happy to actually be in the same space again with coffee and pastries and sort of be sitting at these conference tables and having these conversations. And there's some people that I'm super glad are here today, and I just wanted to acknowledge our support from the FMEC and Scott Allen, who has been a champion of just really everything implicit and trying to help get our organization to the next level. I'm so grateful for Sarah Verbeest and her collaboration with us and helping to sort of guide over this last couple of years, thinking about fourth trimester care. And finally, after 3 years being like in person, something that we like wanted to do in 2020 and have been shut out since that time. Certainly grateful for our colleagues in the Pennsylvania and Minnesota Departments of Health who are here, and particularly for Pennsylvania's program, which has sort of, you know, really picked up this project in its infancy, not to use our implicit terminology, but we were wee babies and got funded for the first time, you know, about 7 or 8 years ago, and that funding has created all of the work that we've seen here, and so really thankful and grateful for that. And last but certainly not least, Maha and Anna and Carolyn and Kendall, who are sort of the core of this network, and who really bring us together and guide these meetings and run these meetings and do all of the work and take all of our comments and conversations and ideas and turn them into something substantial and action items and move our network forward. And I think that, you know, we can talk about data and how we report that and how we sort of, you know, look at that and try to improve our numbers. But our network is really about much more than that. It is about the relationships that happen, the conversations that happen, the vision that we see for how maternity care can be different. And in the last couple of years, we've recognized all of the threats to that. And we've taken a whole lot of new directions around inclusion, around health equity, about community engagement. These are things that are not easily reportable on an R report, and none of us as healthcare providers were really expert in all of those things, and we really relied on those individuals to create a path for us to have this discourse. And I'm so incredibly grateful for their tireless work, effort, creativity, energy, and the work that they put in to bring the network to where we are today. So I just want to say thank you to They also run and keep all of these committees going too. And so I'm really thankful for that because, it's really hard to keep that going as well. So this is a scholarly activity committee, and just want to make a couple notes about that. I don't know that we have a regular meeting time, which is really tough for Carolyn, who runs this, to lots of doodle polls. We do lots of doodle polls. But our next journal club is actually coming up in April, and there's an invitation that recently went out, an email that went to the network with a PDF of the article, as well as an invitation, which also has a PDF linked into it. And so this particular journal club for April is about breastfeeding and some sort of really interesting policy perspectives about what was happening with breastfeeding during the stay-at-home orders that happened in the spring of 2020. And there's a really substantial qualitative mixed methodology component of that, which I think can be really important to sort of like get into and think about how people are impacted by policy and how policy change could support some of the patient-centered outcomes and health outcomes that we're looking to do and looking to see at our sites. And so that one is coming up in April. I will tell you that these journal clubs are intimate events, usually participated in by some of the people that are in this room and not a whole lot of other people on top of that. So we're trying to think about some ways to reach larger audiences to sort of bring them into the fold. I understand that there's a lot of things that happen from CME and academic wise and committee meetings and other meetings and residency meetings and program meetings and things that happen, especially at these hours like after clinic and before dinner, and they're tough times. It's tough to find a time that works for everybody. But do try to be a part of it. You don't have to have read the whole article. You don't have to be super expert in those things. It's just a conversation, and we can think about how that topic area relates to our implicit work, either directly or sort of indirectly, or our work in the care that we provide. So and share it with your residents, share it with your faculty, like just pass it on, and maybe the more disseminated it can be, the more people can join. In our last journal club, we had a cardiologist from Penn that was part of that conversation, as well as a lactation consultant from Rochester. And so if you think that it's relevant to some of the teams that you work with clinically, bring them there and help sort of have them to have some conversations about the network. And that's sort of our goal and sort of action item for this group moving forward. And then this is we're being as inclusive as possible. Like, Scott and Sakanya have mostly led some of the journal clubs. Carolyn has led journal club. And so we're open to have other people leading those. You can suggest articles, pass them along. We just have to do the work of like reviewing a bunch of things and voting on them. And so we're happy to have other people suggest things that they feel passionate about or want to lead. And that would be really, really great. So please do that. Okay, I think that's all for that. Yep, I was getting to that. Okay. The other piece of so it's the scholarly activity, there's the webinars, there's journal clubs, and then really looking at some of our academic submissions. And we can continue to have these conversations internally. We're a really strong network. We have sort of internal communication strategies, but we're really looking to reach out and sort of carry this message and the work that we're doing to the greater academic community. And so we have, I think, infiltrated FMEC a lot, and we're sort of well known in that community, and we will continue to be established at FMEC, hopefully in this fall as well. There were several submissions that you can see here that went into FMEC. It sounds like they'll be reviewing those things. We'll be notified in early May, is what Scott Allen says. But they'll be there. We will have our fall meeting there at that time too. So we hope to bring as many people as possible. There is a submission that the team is working on, our sort of core team for APHA, to think about our health equity data and how this model of care around ICC can be stratified along race and ethnicity, and how we can use that to help neutralize or achieve health equity. Rochester is working on a submission for the American Academy of Pediatrics for this coming year, which I think is fantastic. We should be reaching out more than just the sort of family medicine echo chambers of taking care of mom baby dyads or maternal child dyads, and trying to understand how this model could be picked up and replicated and scaled in other communities and other settings. And pediatrics is a great place for that. The ACOG and OBGYN communities will be a great place for our fourth trimester work as well. And we should need to figure out how we get into these different academic circles. And so if you have connections with other organizations or other networks, or you think that this work can be sort of disseminated amongst a community of either providers or academicians or policymakers or leaders, like, let us know so we can add that. And our scholarly activity community or committee maintains a list of upcoming conferences along with their submission deadlines, and so that we can sort of post that out and we don't miss deadlines for opportunities. Okay, I think that's it.
All right. Our next update is from our Leadership Council, and Amy will be presenting that.
But doesn't want to go stand at the podium.
That's fine.
So the Leadership Council is set to serve as a governing body for the network. We're trying to bring more structure to it, and we're trying to spread and represent the interests and concerns of the participating network sites. I was going to say, you took my notes.
Sorry.
It's supported by MAHA and currently involves Mario, Scott Hartman, myself, Sarah Jones, Brianna Moyer, and Nargis Farahi, and I'm really sorry if I messed up her name. Next slide, please. As we continue to grow, this leadership structure needs to evolve. And we have, at our last meeting a month or so ago, set up different roles. So the proposed roles are a leadership chair, the Secretary of Finance, chair of the network for the network meetings, and then the PA Department of Health advisor to the network and coordinator advocate. At the last retreat, these roles were adopted and will begin for a one-year term starting in July. I will be acting as the chair. Scott Hartman will be the Secretary of Finance. Nargis is going to be the chair of the network meeting, and Mario is going to be the Department of Health advisor. Bless you. Our current projects are trying to identify national health equity partners to work with all of the different sites, as well as identifying potential candidates to represent the network geographically. We have, as the current leadership council, nominated candidates, and they'll be contacted next month. And they'll be expected to begin their term in July of 2023. And if you would like to join the Leadership Council, please contact MAHA or any of us for more information.
Yes, so the emails will be coming out by Dr. Amy Smith next month. So please respond to those emails if you wish to, or if you don't wish to serve in that role. That way we can identify other possible candidates. Thank you, Amy. And with that said, I'm going to invite Scott Allen to please come and present.
Hello, everyone. I appreciated the shout out from Mario this morning or just now, and the thank you, but I really feel like I haven't done nearly what I want to do with implicit since I started with FMEC. So I'm hoping that this is the first of many times I'll be meeting with you, getting to know you better, and really helping to support the network grow, because what you're doing is just incredible, and we need to put a spotlight on it for everyone. I just want to talk a little bit about me and about the FMEC, because I know most of you know who the FMEC is. I think some, now that we're starting to go, especially with implicit outside the 14-state region we serve, there may be some people who don't know much about FMEC. But first about me, I'm Scott Allen. I started with the FMEC at the end of 2021, took over for Larry Bauer, who I'm sure many of you knew very well. and have finally feel like I'm kind of getting it. And it's been a little, almost a year and a half, but I think we're doing pretty well. My history before that, I worked with the American Academy of Pediatrics for about 25 years. I was at the national office for 9 years, and then at this running the Illinois chapter of the AAP for about 15 years. I live in Chicago. And in that capacity, I did work very, very closely with the Illinois Academy of Family Physicians, and we did quite a bit of work that's similar to what you're doing or touches on what you're doing around smoking cessation. We were actually the first state to get Medicaid payment for depression, maternal depression screening during the child's visit. So we did some work in that area, but that was quite a while ago for me. I also worked at the Public Library Association. So if you don't go to your public library a lot, you should. They do a lot of health work, public health promotion. And then just a little bit about the FMEC. I think you can see our kind of core areas of work are on the screen. We cover 14 states in DC, so Ohio East and the Virginias North, but we're very happy to have, for instance, Minnesota participating in this project. And I think some of our projects are starting to kind of bleed outside the 14 state region. I just want to mention a couple things, just some numbers for those of you who aren't as familiar with the FMEC. We regularly communicate with about 219 family medicine residency programs, which is mostly in the FMEC region and a few outside. And about half of those participate regularly in our activities. So our residency fair at our last meeting in Arlington, Virginia last fall had 89 programs represented. So that was a record for us. And we're hoping for even more in Providence this fall. We have an organizational partnership model. So we do have individual memberships, but we actually ask health systems and hospitals and residency programs to join as organizations. And we have about 96 organizations as members throughout the region. We have regular communication with about 4,500 to 5,000 family physicians, faculty, residents, medical students, partner organizations, anybody who's kind of a member or come to our meeting. So how many of you get our email newsletters every month? See, quite a few. If you don't, let me know. I can make sure that you get, but just so you know, those are going out to about 5,000 people, and our regular communications do. And then we had, I'm sure you'll get approved for your 3 proposals there for our meeting this fall. We had 320. I think a lot of you who know FMEC know, our mission is to give people the opportunity to present. We almost don't reject any proposals. Maybe that's a secret I shouldn't share, but so we tend to work with people if we don't think it's quite where it should be and try and get it on our schedule. We had 320 program proposals this year for Providence in October, and that's about 50 more than we had last year. So we think that's also a new record. So we think there's a lot of interest in our meeting this fall. So we're really excited about that. Just want to give a quick mention some of our priorities. We're really trying to grow and strengthen the annual meeting, which has been kind of our star activity for many, many years, but we're trying to do more outside the annual meeting. And so we've done a lot more webinars lately. We're trying to do more learning collaboratives like Implicit. We have one that we just kicked off a little while ago around hereditary breast cancers and narrative medicine. So any and all topics, we're kind of looking for resources and expertise to get those started. And that is related to the new ACGME requirements for the family medicine training programs, because they will have to do interinstitutional learning collaboratives as part of the new requirements. So we're trying to build support for those, meeting those requirements, but also for things like setting up community advisory councils, things like that. We do a lot of work to help residents figure out their next career choices. We do bring, I think some of you know, we bring about 300 students to our meeting every year to help them generate interest in family medicine. And we're also trying to just diversify our revenue. And that's a lot of why I'm here today, is to figure out how we can do that, how we can help support Implicit grow. I think I was asked to do just a quick finance update. I'm not sure there's any reason to go into too much detail on this other than just to mention in the life of the project, it's generated about $500,000 in revenue, which is great. More than that, but then just to point out, it's kind of up and down depending on when we get grants, how many network members there are who pay their membership dues. So thank you very much for the membership dues. We really appreciate that. And thank you as well to our public health, Pennsylvania and Minnesota partners and others in North Carolina. But my goal as the organizational home for Implicit is to make this more consistent and strategic and growing every year. and not to have good years and bad years. Let's figure out the sustainability strategy. And along those lines, and I'm hoping this becomes more of a discussion and you all help me figure out what the next steps are. I am talking a lot to Mario and Dr. Ratcliffe and Maha and anyone you recommend. How can we grow this network? How can we sustain it? We're looking at opportunities like expanding the work we're doing at the public health departments. I think it's been great to see their interest, but how do we then spread that across the country? And so I have a consultant working with me right now who's doing some interviews and trying to figure out what's our messaging strategy to public health departments? How can we work with, say, the ASTO, the Association of State and Territorial Health Officials, to reach other health departments that maybe have an interest in this area and would want to hear what you're doing? Again, we're going to leverage that ACG requirement and maybe see if the network can grow because residency programs are looking for learning collaboratives to join. And then I'm really interested in thinking strategically with you, how are you communicating what your site, what your clinic is doing in your region in terms of, data reports are great. I was an English major. I can't read those, but how can I get the bullets out of that to say, this is the really important work we're doing and work with you and your hospital communications department or your fundraising department and generate some local support for this type of work. I think there could be support at a lot of different levels, community foundations, regional foundations, national foundations, government. I think that's my challenge right now is to figure out where do we go with all the great work you've been doing and how can I be strategic in communicating it and generating resources to continue. So I'd love to hear your ideas. What do you think? Like, are you working at the local level to communicate all the work you're doing through this project? And are there partners at the community level you might be able to engage? And then I could help talk to them about what you're doing. For our public health partners, I would love to hear from you all. How has this been working for your state? Do you see potential to help us talk to other states, to other regions?
Hey, so in North Carolina, we're a little out of your region here, but we actually in 2019, I think, got a big HRSA grant, the Maternal Health Innovations HRSA grant. And we actually wrote implicit into that grant for the whole state. And so we have been working on this model as part of a maternal mortality and morbidity reduction strategy. And so as part of that, each of our perinatal regions has a family medicine champion, an OB champion, and a pediatric champion. And so we actually have been incorporating this as to part of, the pandemic sort of threw a bomb in the middle of it at the beginning, but we're at the point now where we are starting to do some education with our pediatric colleagues, starting to do some outreach in our communities about this. We were sort of wrapping it into a huge project in terms of transitions of care for moms back to primary care, as well as how to identify risk factors and make sure that the risk factors from pregnancy get translated to those who take care of the moms after pregnancy as well. So yeah, so it was really exciting. And I think, when that grant was written, actually, Dan Frayne was part of the person putting that information together. So he made sure that was included. And that was rapidly identified as a way to help take care of that 50% of maternal mortality that happens after delivery.
Great. Well, thank you. And we obviously really appreciate your involvement. And I love that we're moving outside the FMEC region. And I'm hoping that, we can use examples like yours to talk to other states, other health departments, state or local, and figure out how they can engage. Yeah.
So I'm going to wear my Maternal Health Learning and Innovation Center hat. So we are national training and technical assistance for maternal health projects. So also just the fourth trimester stuff I'm presenting was funded under the same mechanism. So Pennsylvania, they're going to be they're going to be funding 22 more states for maternal health innovation, and they're going to drop that soon. So I've been thinking, how do we let all the other states know about how awesome this model is, so they might write you in? So we definitely have a symposium coming up, and we are accepting proposals, and I'm on the planning committee. So maybe put some in. And we're doing an in-person and a virtual meeting, and the meeting is in Minnesota. I'm also in my head wondering if we might want to do a national webinar to highlight your methods sooner than later and advertise it to everybody. So again, it could generate ideas as they're writing their maternal health innovation grants. And then also, I think for those of you, Ohio has one and Minnesota has an MHI. So getting involved in that maternal health coalition work would be a way to get visibility.
Great.
Anyways, and I have lots of other thoughts because this work is like transformational. So we can talk later.
Yeah, I really appreciate that. And I would love for anyone, definitely you, but anyone else, I'd love to have one-on-ones and just kind of brainstorm where we can go. I feel like my role, and I mentioned when I started, I don't think I've done enough for implicit. I want to do more. And my role is to really kind of synthesize what you're doing and share that message with, funders, with foundations, with government, with the media, with community partner, organizations that oversee those community partner agencies that you're all trying to connect with. So I think that they would all be so impressed and they'd want to be a part of it somehow. Scott, did you?
I was going to say, in New York State, we've tried to do what you did in North Carolina, writing implicit into part of other grants, and I don't think we've been as successful. We'll get like $5,000 instead of whatever. But I think that's a great model, and that we all should continue to promote that. If it's whether it's implicit by itself or something that's related that you can sort of build into part of that grant. And so my question related to that for you, Scott, is are there grant writing staff part of FMET that can help support us on that?
I am the grant writing staff, which
Okay.
it sounds a little scary, but I actually have quite an extensive history in that. I took the Illinois chapter of the AAP from a $200,000 a year organization to a $2.5 million organization. So I love grant writing, private foundations, government grants. I've done it all. I love it. So if there's an opportunity, pass it my way. But no, FMEC really has been a very small staff. It's been the CEO, Larry, and now me. And then there's about 4 staff who really just focus on the annual meeting. There's not a lot of association management or fundraising or medical education skill experience in that group. It's really just putting on the meeting. Other suggestions, ideas? Does anybody work? I know you've got all these great committees. I don't want to like add one, but if anybody ever be willing to work with me on kind of the communications marketing strategy for implicit, I would love to hold a call or two about that, because I'd love to hear how you translate all that great data into a couple key points that will engage community members and supporters.
I don't know how much time we have for this topic. I mean, we could spend the rest of the meeting actually talking about sort of the things that are on this slide. First of all, thank you for, I think, sort of introducing us to the national stage when we talk about what a sort of learning collaborative can look like. And I think that's it was really nice to be a part of sort of a group thinking about ACGME changes at FMEC this past year. Stacy Bartlett will be representing implicit, I think, at a summit in Denver coming up in a week or two. And we'll have a chance to talk to the STFM audience about sort of, basically implicit as a really good example of what a regional, like a learning collaborative can be. And I think that, and Steve Ratcliffe is presenting in Portland this summer to include implicit as sort of the evidence-based practice around interconception care for a national audience of, physicians and midwives that do family medicine OB. And that's the AAFP CME that's put on annually. So I think that there's, these are opportunities, I think, where we really can get this message in the model out to a larger community, and we need to think about how to present it and package it. But I also think we need to think about what it is that we would like to expand and scale up, because it seems maybe unnecessary to sort of scale up the exact thing that we've done in Pennsylvania for all of these years. And with this sort of network so far, to establish, the feasibility, the data, to share that data, we should really, we had a conversation yesterday with the team, about what this future is going to look like. But maybe we have the data that we need to sort of just really analyze and publish and disseminate. And the future is not about sort of how places share data with, Red Cap and in Lancaster and, give a pile of data that, makes taller than Mike. But maybe about just sort of like teaching the clinical skills and sort of sharing our methodology and being a CME or a sort of, educational support, to those sites. Or maybe it is about sort of like how to do the things like creating the community engagement. How do you have a community voice in your work around maternal child care? How do you do the clinical skills like a like a postpartum visit that's patient-centered and introduces a whole new skill set than we were trained to do in residency? Or how do you do contraception counseling that is more patient-centered, and how do you, like, what are those clinical skills? So I don't know, part of that is an identity issue. So when we think about expanding to other funders, it may not just be replicating what we're already doing, but sort of what is that going to look like?
No, I agree. And I appreciate you bringing that up, because I did want to mention, and Maha and I had talked just briefly about this, that the current model probably isn't sustainable to just keep adding sites and adding sites. I think Maha and the others, and we'd all be kind of like, oh my God, what are we going to do? But there are elements of what you're doing, like you mentioned, that could be kind of packaged and done differently, and I think that that's kind of my job with the team, is to figure out what's the growth strategy, what's the, what do we want implicit to look like in the next 2, 3, 5, 10 years, and then figuring out who's interested in supporting pieces of that. And it may not be exactly the same model, but there's a lot of great work you've been doing, and just like you mentioned, there could be just straight education pieces we pull out that we have a good audience. And so there's a lot of work to be done, but I'm kind of here to say I want to help. So please share your ideas, and let's keep going.
And just towards Mario's comment about time, we are running ahead of schedule, which is awesome. So we do have until 12 o'clock, which is lunchtime, to have this discussion.
I'm kind of done, but I'd love to keep talking if you have ideas, or talk one-on-one the rest of the day. So
one model that we've had, we've really been thinking about, and maybe we can talk a little bit about this, is to say, we had this funding from Pennsylvania Department of Health, and we needed to we know it's not forever, and what's the next level? And for us, the next level funding was federal dollars, which are much bigger budgets to do much less work. I mean, not less work, but to answer a smaller piece. I mean, we're doing a lot in a lot of fields and a lot of domains, with a lot of sites, with our PEA, DOH funding. And so, but that makes it really hard to sort of like have the capacity to do strict trials. And so, working with Emily Gregory and Scott Hartman has trying to get some federal dollars, and Amy Smith has submitted for a HRSA grant that they'll hear about in September, to try to, use the implicit model as sort of a, like a evidence-based scalable model that can improve maternal health outcomes, which I think is amazing and wonderful. And those budgets are twice as big as our annual budget. And so how those sort of play a role, like I no longer think that that's the only thing that we need to do to sort of keep this going. I think we just sort of need to pivot and figure out, well, what are the domains that we really need to figure out. And so for Emily, thinking about, what is it about a site that makes implicit work or not work, so that we know when 100 new sites sort of join, what are the factors that can sort of drive, be facilitators of that implementation or not. And also whether or not this model is having the intended outcome, which is to improve birth outcomes, which we've not been able to sort of establish yet, but it turns out it's complicated to figure out how to look at our outpatient data from implicit sites and compare it to birthing outcomes at hospitals, and have a control group that didn't get exposed to implicit and like answer that question, which, like none of us are really ready to like we don't have that capacity, but like, collaborating with research teams that do have that ability to sort of, get in and answer those questions, I think is a really important piece of this. And it doesn't just have to happen at Penn or at CHOP or at Rochester. I mean, it could happen at any of our sites, and just thinking about that being a really important piece of this, but not the only piece of sort of what implicit looks like in the future.
I also think there would be significant interest among some private foundations and funders in what you're doing to connect the clinic system to the larger community and the different resources that parents and families need, which may not be quite as much research, but I think there's things we can do that are just that don't require the same level of data management and research output that some of the public government funders require. So I'm really interested in thinking about that and thinking about who some of the big national foundations are that want to see this kind of work. And I think they can be much more flexible about what their outcomes are.
So one thing that's been really big are the perinatal quality collaboratives. I'm sure for the PQCs, they're everywhere. And they kind of started small and now they're huge and they're getting funding from CDC, a lot of funding. And then the ACOG is creating all these bundles, and now they're implementing the bundles, and it's like a whole thing. It's very hospital centric. Largely, they're trying to expand to maternal, but I just think it could be an interesting. I'm not proposing you replicate it, but there's a lot of lessons I think learned from how they got started, the success, the pain points that might be worth taking some time to explore, and then see if there's a retrofit or there's some key components from that approach that you all might want to consider, because there is some power in big data and big networks, but some challenges too. So, but it's like, I think every state has a PQC almost, and it's a lot of money.
Great. Well, like I said, I'm here today. I'm available anytime. Let's keep this discussion going. And thank you again for all the great work you're doing. And thanks for the support from your individual sites and the 3 health departments we've got here, because it's making things happen. If you don't already know, annual meeting, October 13th or 15th. I know Implicit will be there for your meetings and for your programs. If you've never been to Providence, it's a really incredible small city, and the convention center, we have the whole convention center, which sounds huge, but it's a small convention center. It's going to be a really fun meeting. So please plan to join us.
All right, so since we have time, let's get started with discussing our 4th trimester data. So Mike, I'm sorry, I'm pushing you up. Wanted to share our summary data.
More data before lunch. Whoa.
It's better this way that we don't fall asleep after.
Right. Did you want to say anything about the sites and the timeline, or Anna? I don't know if you wanted to preempt that.
So just as a reminder, the 4th trimester project, we started this in 2018. So before pandemic, before my time, we started collecting pilot data. Our pilot data we established for the time period from July 2021 to June 2022. Whew. So we have collected that data from our sites, and we are now in the process of analyzing that data. So we have moved past step 7 and are in step 8, presenting this data at the spring meeting. And then from here, we are going to be, luckily we have a session today during the spring meeting to really work on editing some of that 4th trimester and looking at that data. And the goal is to make those edits, to work on creating an EHR build similar to what we have for ICC, and kind of package up that 4th trimester project so that it's ready to be implemented at other sites that are interested. And our goal is to have that done by the fall meeting. And then this is just kind of a reminder of the sites that are currently participating in the pilot. We have 3 sites from New York, University of Rochester, and the 2 Institute of Family Health. And then we have the Lancaster sites, University of Pennsylvania, and the rest are UPMC sites. So all of the sites are kind of in various stages. Some have only implemented one part of the 4th trimester questionnaire, maybe the postpartum. Some have maybe implemented 2, some have implemented all 3. But we're really gathering information from that pilot period to understand where are the challenges and where do we need to improve that before we open it up to have other sites join.
So I'm going to just kind of run through some basic descriptive data that we have collected so far in REDCap for the 4th trimester. We have a report for 4th trimester as well that's similar to what ICC does, but it's much more in its infancy. So it's kind of descriptive at this point. There are some options. We did add some options to isolate it to a site or a time frame or whatever. So again, if you're participating in 4th trimester and want a deeper dive into your data or some things, please let us know. So at the fall meeting, I did do a basic overview of what's happening in 4th trimester. And so this is kind of an attempt to show the sites that are submitting data and what they've accomplished since the fall meeting. So the purple areas represent the number of moms or birthing persons that were submitted and that were presented at the fall meeting. And then the green is what was additionally added up until today, essentially this meeting here. So you can see for example, University of Rochester, entirely green. They were a recent add since the fall meeting. So I have a number of demographics just to show, and these graphs are come right out of the report, so that the axes labels are a little bit fine for folks sitting way in the back. So I think Anna's working on emailing this out to folks. Again, it's an HTML report. There's an index, and you can easily jump around in the report. And I'm not going to present everything that's in the report. These are just some of the highlights of the key data. But this is the maternal age. So we have categories, age less than 15 over on the far left, 15 to 17, 18, 19, 20, 24, all the way up to age 45 plus. And then the bar on the far right is the missing. So we have about 10, almost 11% maternal age is actually missing that are currently in the database. But you can see the distribution across the various age categories. Insurance status, we have medical assistance on the far left, then we have private insurance, self-pay, unknown, and then we have about 21% missing. But again, similar to ICC, almost 60% of our moms or birthing persons are medical assistants. And so I think it's very important kinds of data to present, particularly for funders and so on, the type of population that we're serving. Race and ethnicity. Again, so we have these are all the race and ethnicity categories that are included in the data collection form. And again, this one's in blue just simply because this is again one that a mom can be in multiple categories. So the percentages will add up to more than 100%. But again, on the far bar on the left is white, and we have Black, African American, and we've got American Indian, Alaska Native, Asian, Native Hawaiian, Pacific Islander, other, Hispanic or Latino, unknown, Middle Eastern, North African, and then finally the 13% on the far right is missing. So the missing in this case would be that none of any of the other options are selected in terms of race or ethnicity. So just delivery method, we collect delivery method as part of the prenatal, or essentially what's the planned delivery method. And then we also collect delivery method, what actually happened as part of the hospital phase of the data collection. So this is the planned delivery coming from the prenatal screen. So we have about 87, almost 88% planned vaginal delivery. And then we've got a attempted vaginal birth, a previous C-section, VBAC, and then we've got planned primary C-section, and then a planned, essentially a planned repeat C-section. And then if we look at the actual data from the hospital side, We've got 70% spontaneous vaginal assist, 2.4%, 20 planned C-section was 20.9, and unplanned C-section another 6.2%. In the report, I had created this kind of funky diagram, just trying to show what the relationship is with the plan versus actual delivery. So on the horizontal axis in the bottom, that's the actual planned delivery from that prenatal screen. And so we have vaginal, VBAC, planned C-section, repeat C-section, and then this NA column, this really wide NA column, those are all the missing in the prenatal planned delivery. Those were essentially missing that were included in the screening form. And then the color coding represents what actually happened at the hospital. So if you look at the column on the far left there, we had 200, that purple section, there were 209 planned vaginal in the prenatal phase that actually then were spontaneous vaginal in the hospital screening form. So it's a way to just kind of it's almost like a scatter diagram with categories where you're looking at what was the plan versus what was the color-coded actual. So looking at a couple of the key factors that were collected from the various screens, the prenatal, the hospital, and then the postpartum well checks. So one that we get asked a lot about is the contraception method. So this is a question that's collected at all three of the screens. And for all of these, I have them color coded. So purple is the prenatal, blue, the light blue is the hospital, and the green is the well check or the postpartum visits. And so on the vertical axis at the top, we have the no method. The second one there is the abstinence or not sexually active. The next one down is what we currently call the third, tier 3. And then we've got below that the tier 2, and then tier 1 permanent sterilization. And then the lowest one is the tier 1 IUD or implant. And so you can see the relationship there. So the percentages are calculated within the screen. So you can see, just in terms of seeing, are we seeing any, movement across the screens in terms of the planned contraception methods that, during these three time points. And of course, there's implicit color coding. So we're being very, very colorful. Actually, they're very nice spring colors. So
Mike, that's all the whole cohort, right?
yes, this is it. This is everybody that we've got in the database thus far. Now, obviously, there are instances where we have missing data in all three of those screens. So we might have a mom that's only represented in the prenatal, but not in the hospital or the well check, or some other combination. But this is essentially of those that are completed in the contraception question. This is what that breakdown looks like. We collect the feeding method at both the hospital and the well check, and I think the proposal is to add this to the prenatal as well. So we'll have a purple bar in here eventually, but for the data that we have collected thus far, so the top set of bars are for formula only, then the middle set is breastfeeding and formula, and the bottom is breastfeeding only. So again, no surprise that in the hospital phase, we have a higher proportion saying breastfeeding only. And then you see the increase when we get to the well check in the use of formula only, and the decrease in the breastfeeding only. So no surprise there. And Scott, I think you're doing all three, right? When you capture the prenatal as part of your internal data collection, correct?
But it's by manual chart review, so it won't be not sustainable long term.
Right. I did include the depression screen as well. So we have the top bars representing none, then bipolar disorder, postpartum depression, and then major depression is the lowest. So we collect this screen at both the prenatal and the well check. It's not screened at the hospital. So
Just for clarification, is that 35%? The positive depression?
yeah. And again, they're missing that, you know, of those that we have a completed. Where depression was identified. I mean, that you can see the none up top there. We, you know, about 56% are saying none, but yeah. We collect a whole host of biomedical risk. And I know at the fall meeting, one of the questions came up is, you know, can we eliminate some simply because you can see a number of them there. We have very low numbers of individuals that are screening positive for these biomedical risks. So we collect the biomedical risks at the prenatal and at the well check. The top bars that are hidden there by a little bit by the Zoom toolbar, that's the none category. And then all of the others, if you have, I mean, I won't go through and read all of them, but you know, in terms of the risks, I mean, at least from the none perspective, you get a sense that at the prenatal, we have about 57% saying none and about 65% saying none at the well check screen. We also collect intrapartum complications at the hospital and at the well check. Again, up there at the top, it looks like about 65% are at the well check and about 62% at the hospital visit are screening negative, or essentially none. And again, both the biomedical risks and the intrapartum complications, it is a check all that apply. So you can have moms that are in multiple categories here as for both of these as well.
What are the bigger ones down at the bottom?
So that one right there is the gestational hypertension or mild preeclampsia, and this one is requiring magnesium sulfate. And again, I apologize. These were scaled for these graphs in the report, so it's much better reading when you're sitting there looking at your laptop than projecting them up on a screen. So,
I mean, just for starters, I think we were trying to understand the prevalence of these things in our population, and those numbers seem like they make sense to me, although still, I think that our gestational hypertension is like higher. And then there are those things. I mean, these are real complications, serious complications. I'm glad to see that there's less of those, but and just on face value, these look like we're getting accurate, relatively accurate data. But maybe we should, part of our meeting today, I think, is for people that are working on labor floors and taking care of these patients, like, are these, like, are we getting this data? Is this like right? Or are we just sort of missing a lot of the data? Are we only doing this for people who have risk factors, things like that? So
right,
maybe we can, part of our time to be that discussion.
Right.
Can I ask one question as well? Do you mind going back just, I guess it was to the, so the purple is prenatal and then the green is
well, at the well check, the postpartum, yeah.
Okay. I'm just curious about the risk factor change. Do we think that that's just something that happened within, that would be something happened within the pregnancy, right? Within the delivery, potentially, if we're, although I was thinking we're having these are different groups of data, right? Because like at UPMC, we only do 2 sets of data. So it wouldn't necessarily be the same cohort of people that we're looking at with this.
Or they could be missing too. I mean, they may not have been screened, you know, that mom with that risk may not have been screened at the well check, but was included in the prenatal.
Okay. Okay. Thank you.
And that would be something too, you know, potentially, you know, creating a cohort where we have measurements for both to look at that delta over, you know, see if there is a delta in one where we have the measurements for both, you know.
Sorry, how are the pilot sites thinking about women who may be receiving care from implicit site physicians, but also getting care from MFM with these, like, are you only, like, who's getting screened in the hospital, I guess is what I'm curious about.
Probably depends on the site. I'll let the clinical folks answer that one, but.
So we are at Lancaster doing the screening in the hospital. And so we are screening any patient that is cared for by our residency service. So we have a lot of patients who, like MFM, at least in our hospital system, does not come in and deliver or anything like that. They just consult on the outpatient standpoint. So even if they've seen MFM, we're still delivering. So we're screening any patient that our residency program is delivering in the hospital.
Any other sites want to comment on how they do it? Or
I think there's a lot of sites where the hospital discharge is not being implemented right now. We have a couple sites that their inpatient and outpatient EHRs are different, so they're not able to implement right now. And we've definitely found that the hospital discharge portion is the hardest to implement. So it's one we definitely need to problem solve and figure out how we can better integrate that in.
One of the key project objectives, just looking at the well check, just in terms of these postpartum visits, when they're completed, and are we getting folks back in a timely manner. So this is just a simple histogram looking at the number of the horizontal axis is the number of weeks since delivery. And for all the well checks that we do have recorded, you can see that distribution of, and again, we may have, I know at least on our site, the way I pull all of the well checks, you have some moms that come back multiple times in the first several weeks for, either clinical problems or just a normal well check. So this in some cases, we do have moms with multiple well checks in the database as well. So, but this gives you a sense of that distribution in terms of that timing of the well checks being completed. The average is about 3.4 weeks. Based on this distribution. Then one of the things that I did in the report is identify the first well check that occurred. So if you have a mom that had more than one well check, we just pick the first one and then we categorize them. So over on the far left, we have the well check within less than or equal to the first week. The well check within the 1 to 3 week range is the second bar. The well check greater than the 3 weeks. And then we've got the a well check where we know it happened. It's in the database that it happened, but there was no data recorded in terms of the number of weeks. And then finally, the last bar is there's no well check recorded at all. So we had 30% of our moms that we have no well check recorded at all that's in the database. And we've got about 55+% that are in that 1 to 3 week range in terms of what we've got in the database right now. In the report as well, there's a breakdown of that same on the horizontal axis. It's the same well check breakdown in terms of those categories. And then it's broken out by all of the biomedical risks. Again, just trying to ascertain, are there any, certain types of biomedical risks that we're not getting these folks back in early for these postpartum checks. It's a little hard to see, at least on the screen here, but these are color, the darker the color, the closer to 100%. But it's intended to kind of be a matrix showing the percents are calculated within the row. So within those that report these particular biomedical risks, that's the distribution in terms of when they actually had their first well check at the postpartum visit. And then similarly for the intrapartum complications, again, it's the percent within rows that came in within, whether less than 1 week, less than or equal to 1 week, 1 to 3 weeks, greater than 3 weeks, missing or no well check at all. Getting a sense of, are we getting some of these high risk moms back in for those checks?
Because if the baby's in the NICU for a long time, then obviously they're not gonna have a well, right? If you're relying on the infant well check, you might have a delay.
Maternal well check.
Oh, this is a maternal.
Postpartum visit.
Right.
Yeah, that is a complicate, like I don't know if it's listed here because it's listed in the hospital discharge as a complication that the baby went to the NICU. Is that also in the postpartum note?
It's only in the hospital discharge.
Yeah, I was gonna say, I think it's. One of the things that I added recently to the report, excuse me, in terms of some of our work around health equity is breaking some of these things down by insurance, race and ethnicity, and maternal age. So I'm going to just show you a couple examples from the insurance and race and ethnicity categories. So this gets even harder to read because you're looking at all of the sub classifications by insurance type. So for example, that in the upper left quadrant, that block is the Medicaid medical assistance group in terms of the contraception across the prenatal, hospital, and well check screens. So you're able to look at Medicaid medical assistance, and then the block in the middle on the top row is the private insurance group. And then we've got self-pay over here, and then we've got unknown in the lower left quadrant, and then the missing. So the missing group are essentially all of those that do not have insurance marked at all in the demographics. But again, you can parse this out and start looking, are we seeing starting to see differences across the contraception across the various screens within these insurance categories? And then this is the same breakdown by race and ethnicity. So we've got white, and then hidden under the Zoom toolbar is the Black or African American. We've got Hispanic, other, and missing. So I did, for these summaries, I did collapse some of so the other group includes some of those other groups that we include in the race and ethnicity piece in the demographics. And then the missing would essentially be that particular mom doesn't have anything marked in the race and ethnicity categories. Feeding method. So again, this is feeding method by insurance type. So again, Medicaid medical assistance is up on the upper left-hand corner. And then the middle one here is the private insurance, self-pay, unknown, and missing. And again, the blue is the hospital feeding method, and the green is the well check. So, I mean, you can see with the Medicaid medical assistance, you look at that transition from the hospital to the well check in terms of that breastfeeding only, formula only, and comparing that to like, for example, the private pay. Definitely some differences there in the feeding method. Similarly, race and ethnicity breakdown for the feeding method. Again, the blue is the hospital, green is the well check, and then we have white, Black, African American, Hispanic, other, and missing. And again, with race and ethnicity, you could have a mom in multiple categories depending on what was selected in the database. And then finally, some of the last ones that I just recently added is the information that we just looked at in terms of the well check. Again, the various categories starting at the bottom bar in each one of these panels is the well check less than or equal to 1 week. The well check, again, this is that first well check that's recorded. Well check within 1 to 3 weeks, well check greater than 3 weeks, well check missing. We know the well check was done. It just doesn't have the weeks marked, and then the no well check is at the top. So for Medicaid medical assistance, that's the first panel, private insurance, self-pay, unknown, and missing. So again, looking at how are we able to get these moms back in for these well checks across the various insurance categories. And then finally, the exact same thing by race and ethnicity. And again, some of this is site dependent. We have some sites that are very heavy with certain race and ethnic groups versus others, but again, starting to parse this out by some of these subgroups. So the fourth trimester report is still relatively new. It's primarily just descriptive at this point. We're still kind of in that pilot phase. So, you know, if you guys have suggestions on things that would be helpful to kind of like the ICC report, which is a lot far more mature. If you have thoughts or suggestions of things that would be helpful to parse it out, you know, please let us know, because, you know, things we can start to incorporate and, you know, put on the to-do list in terms of updating that report. Any questions?
We will also bring Mike back up after lunch, just in case there's any questions because I know we're close to lunch. So if you need to let the data percolate.
Thank you so much. Thank you so much. All right, so if no questions, let's go into lunch, and we'll be coming back at 12:45 then. All right, you're excused. Lunch is served in the back.
All right, we're gonna go ahead and get started again. We're gonna ask Mike to come back up here and give the opportunity if anyone has any questions about fourth trimester data.
Anybody have any questions? Or is it nap time?
I might have to ask Carolyn this, but it looked like Nikki's part only gave fall data. Is there something I should have done to get the spring data, or do we just not have it? Meaning we didn't have the numbers, or it might be a Carolyn question.
Probably not.
It was like one little sliver of green. So I didn't know if that was something I was supposed to do. I mean, it's likely it was. But
Yeah, we have the data. We just, since I have to hand enter everything, I haven't entered all of spring's data yet. So we're a little behind in the data categories. So that's why you see all of our fall, but not all of our spring.
Right. It was all purple, but no green. Okay. Well, we can talk offline, but Shannon is looking for more hours. If you need her to enter stuff, this might be the time. So thank you.
Just to comment about some of those slides. I mean, we're seeing that for the first time. It's really exciting, and thinking about intendedness from prenatal to hospital discharge to the sort of postpartum visit is for an individual something we'll have to think about collectively. When you see the aggregated data, you know, we can easily see that there's differences from prenatal to that postpartum visit, and I think understanding what drives those changes is going to be helpful. Just looking at this level, it seems that the demographics, which might represent social determinants, have more of a influence than some of the individual sort of medical conditions, you know, or the risk factors that we're sort of identifying, which is probably maybe a little bit different than sort of our ICC model, which is sort of the same thing applied universally to like all of the patients, regardless of risk stratification. I'm sure we'll hear, you know, more about that, but I think it's interesting that we may need to use those demographics more important, you know, like more regularly to understand our fourth trimester data than we did for our ICC work.
Mm-hmm.
Do you have any, like, I mean, if you're looking at those sort of changes from what happens in terms of prenatal intendedness to like the postpartum visit, the people who like intended to breastfeed, but then were formula feeding, or it seems like the drivers were whether you had Medicaid versus private insurance, or it was,
What's this one?
there you go.
Yeah, no, yes, I think there's definitely some things we need to tease out there. And I think one of the things we just added to the report was the ability to, there's an option you can now select when you run that fourth trimester report that will exclude anybody where we didn't have the screens from the other. So essentially it's more of a complete cohort to say, oh, we have a screen from the prenatal, we have one from the hospital, and we have a postpartum. Now, within those screens, there may be some incomplete elements, but at least saying, hey, there was some attempt to collect data from this individual at these 3 intervals. And I think just kind of as a sensitivity analysis, it'd be helpful to look at that and say, okay, how does that differ? Do our conclusions match up with what we're seeing in just including everybody, regardless of whether it's complete or not? So I think that would probably be an interim step we need to do just to kind of get a better sense of, and I haven't spent a lot of time looking at that particular set of data, but yeah, I think, and just in the public health sphere, you see so much being done in terms of these social determinants of health, even defining what is a social determinant of health and recognizing the limitations of some of those measurements, the ecological fallacies of making assumptions. Well, you're in this group, then, does that person necessarily represent, does that grouping necessarily represent the true status of that individual or not? But I think it's a ripe space to be able to, tease some of those differences out and think about what are the implications for clinical care, how do we then change practice to match that? So yeah, I mean, there's a lot that we could do. There's a ton that we could do, but.
From your level, I imagine this is possible because anything seems like it's possible with Mike in our report, but could you collapse all of the biomedical risks or the psychosocial risks to say like any positive anywhere in there, give somebody a risk positive rather than sort of slicing it into all of the different sort of conditions? Because really like preeclampsia versus cardiomyopathy versus a DVT, like we're going to have the same expectations for follow-up for a lot of those things, and the same for anybody with a psychosocial risk. So I'm sure you haven't done it, but would something like that be possible?
Yeah, I was oh, there we go. I think that's a great suggestion. And I know let me get to oh yeah, here they are. And I guess the question would be, do you want to further stratify it? Are there some that you would say maybe as a tier 1 risk versus maybe at a higher level tier 2 risk that would say, okay, we know the percent, I mean, I could just collapse them all and say, Jeff, or any of them, yes, but we could also do something that would say, oh, these are important, but they're one level versus, oh, these are much more the types of clinical interventions, the types of downstream risk are higher, and we want to tier it in something like that. So we could do that, and that would be an excellent thing to add to this particular report.
And then a few years later, we can go back and take the word tier out of all of it.
Right. we can come up with another word if that would help.
Mario's got the jokes. Any other questions? Any questions from virtual audience? All right, if there's no other questions, then we're going to go on to our next presentation.
It's really nice to have someone to do all the time. We've been doing a lot of tech these days, so it's nice to have building that. You'll help me with the video if it doesn't work. We'll touch and go there for a second. Hide photo. Great. Well, hi, everybody. Thank you so much for letting me come to your meeting. This is really exciting. I as I mentioned, have been a longtime fangirl and have actually enjoyed lots of conversations with Mario and team. I don't know, over the past 5 or 6 months, just calling and talking about postpartum. So I'm really excited to be here. Is it a down arrow here? Or just this little thing? We'll just do that. I don't need to see that. Stand by. Now that I hit that. The slides have a lot of pictures, so it kind of broke their system. We think pictures are important in stories. There it is. Okay. So while they're pulling, oh, there we go. So I'll tell you a little bit about the fourth trimester project while we're getting started. Oh, there it slides. Just wait. I have to say, it's really crazy. I have to come to Philadelphia to see my colleague from Wilmington, North Carolina. And also, we have a community of practice on postpartum health in North Carolina. And yesterday, Nargis presented about implicit. So I feel like there's just like multiple circles coming around. So the fourth trimester project, we are a group of co-founding mamas, as we call ourselves. And we have been working together for quite some time. We are, thank you. Okay, great.
We're not working on the Google slide.
So a group of, I just really wanted the picture on that one. We'll just wait.
Carolyn, can you see that?
Yes. This is bringing me back to like when we all of a sudden had to teach online and you're trying to like figure out how to look cool in front of your students and like share your slides and do breakout groups. And 2020 was not my favorite. Let's put it that way. I did it right. And just screen.
That's what it was on.
I'm not hearing them. I don't know why it's not. And I didn't pull this out because I just I'm not going to go over all of these. You don't like them, you can keep them. So, and then I only have like some of you that will have to be a little bit more of a sample of some of the stuff that they have with.
Let me just make sure we can move them.
Yes. Oh, they did it. They are so brilliant. What a wonderful team of minds you have. Thank you. Okay. Okay, so the mission of our fourth trimester project is nothing short of transforming the lived experience of the fourth trimester project by sparking real and sustained change. So just wanted to talk a little bit about us because I am just one of the co-moms, and it's some things that are really important for us are, first of all, thinking about our positionality and all of the other voices that we bring into the space. So the bottom corner are folks from Mama's Village, Fayetteville, and they worked with us to design newmomhealth.com. and have continued to provide feedback on tools. And that's just a small group of them. The purple picture was formative work that we did over 2 years with moms and also amazing family medicine folk that were in that picture. And that was just 2 years of listening to women about their experiences of postpartum and getting from them research questions and strategies that they wanted to see happen. And then in the corner is just some of the team of moms that's over there. And then, like I said, we talk a lot about our positionality, and we try to really keep in mind kind of all of ourselves that we bring to this work. And so that was me a few years ago. And when my older child was born, I remembered that experience. I had wonderful care, great midwives, but nobody told me what would happen. So and I had just gotten my master's degree in maternal and child health at Carolina. I worked in the MCH department, right? I knew to take folic acid before I got pregnant, but I had no idea about what was happening to my postpartum body. This booklet, Taking Care of Me, this is my catharsis from that experience where I was like, nobody told me. And so that was kind of the start of this real passion for postpartum. And she's 26 now. So that says about how long we've been working on this. But we also talk about really trying to stay connected with what that early experience felt like. I think we can so easily forget how much is happening in that space, not just with the physical experience, which we at least should cover that well, which we don't, but the emotional, the understanding who am I as a person in the context of this changed identity. What is this doing to my relationships, my sex life, my social life, my financial life? There's just a lot. And so it's a really tremendous and special place to work. And for those of us that I in the power and privilege wheel, I'm pretty much in the center. And if postpartum kicked my butt, I can only imagine what it is for someone that has to return to work 10 days to McDonald's. So some of the work that we've done together is thinking about information and resources by moms, for moms, and birthing people. Knowledge is power. And so we know we can't rely on providers, except for y'all, to give really good information. And so the first thing that we did, and this came out of that early group, was that we needed to get information out there. We've also partnered a lot with providers to help improve the care that they're able to give. And we do a lot with feedback loops, not just from patients, but also from providers, because these kinds of things have to work for everybody in a setting. We've also done a lot to really advance and think about policy. And so how do we make this a more resource-rich environment for postpartum healing? And we also don't think surviving postpartum is adequate or surviving birth is adequate. We really want to think about thriving. And just to set some context, because thriving is not happening and actually neither is surviving. So I'm not sure if any of you saw the CDC just released their 2021 maternal mortality data, which saw an increase of 40%. 40% in 2021 in the United States. You can see from this, well, maybe you can't because it's hard to see, but the maternal mortality rate for Black women in the United States was 3 times higher than for white and Hispanic women. So the rates went up for everybody, but continue to be significantly higher for women of color. And just by comparison, I think our rate is like 32.9 in Israel, Japan, Australia. It's 2 to 3 per 100,000. And so, this is a clarion call, and this is still happening after we've had the awakening that happened in May of 2020. So while people know that there's issues and there's an inequity, we are not going in the right direction. And so as we look at the maternal mortality review data, I mean, it really just makes the case for why what you do is really important. We have got to be paying more attention to postpartum. As I'm sure you've seen this data, it's not new, but over half of deaths are taking place after someone is discharged from the hospital. Other data just from the maternal mortality review committees and as part of that CDC report is that they've determined now that 84% of these deaths are preventable. 84%. So that was this is why your work matters. So a couple of things, this is just sort of all kinds of stuff in this presentation. And so this was something that I wanted to mention. So I put it near the beginning. But my colleagues, Dr. Stubbe and Tully, co-edited a special issue of Clinical Obstetrics and Gynecology, all on postpartum care and support. And I just put a couple of the articles up here. They are not open access, but I think most of you have access to libraries. There's the diversity of perspectives of the authors is something that's really, really important. And this is just a smattering of the articles. I think there are probably some really good ones in there for your journal club. But wanted to lift up that as a resource that just came out September of last year. And so something that Mario said that there was an interest from folks is, how do we engage community and how are we listening? And I wanted to just start with that because the things I'm saying are things that we've heard from this listening as well as from our own studies. And so it's really not hard. I think you just have to have an intention to want to do that. And so really, it's just about building genuine partnerships with local organizations and doulas who are providing community-based services for new parents. There are so many groups out there doing this work, often on a shoestring budget out of love, but they're not that hard to find. So I want to note Vina Standard works in our family medicine department at UNC. She's a certified nurse midwife, and she's a part of the postpartum team. And so she was a conduit to this particular group in Greensboro, which has continued to be an incredibly rich partnership and collaboration. And I feel like there's more and more groups emerging, many of them led by amazing Black women in your communities. Black Maternal Health Week is coming up in April, and there's so many great activities happening. So maybe just pay attention to what's happening in your community. And that's one way to get to know folks. Some other things, and we found that people want to offer feedback if they think that their feedback is going to actually be heard and received. So people will review your materials and give you feedback. You just need to pay people. So that's kind of important. And it's also great to show up at their events and sponsor their events and be available to answer their questions. And you don't have to have relationships with like 20 groups, find a couple of groups that you can build real relationships with your clinic. And that's a great place to start. So I just I think sometimes we feel like this takes so much time. I mean, this is what we always hear. It just takes too much time. And it doesn't. And it's also really awesome, like fun. It makes your work fun. And the feedback and insights that you'll get about your clinic and your services are just invaluable. We can talk more about that later, but I just wanted to start and center those folks and those voices. So I'm not going to dive into this, but I just wanted to give an example. So as we mentioned earlier, currently Fourth Trimester Project is funded with money from the Maternal Health Innovation Grant. So we started off we looked at ACOG's postpartum bundle. And we started designing tools to support the implementation of the bundle. And so with some of our early tools, in the first year of our grant, which was all 2020. So we did listening circles on those materials and the needs. We did them with a group of folks that were from Family Connect. So those were nurses who were going into homes in our community to ask them what they saw as needs. We talked to Mama's Village Fayetteville, and then we talked to new moms from the birth center. So we also trying to get lots of different perspectives of new moms. And so the columns were just like kind of what themes came up where. And we heard a lot of barriers to accessing postpartum care, and how difficult it was for moms to advocate for their needs. And we also saw a lot of people as thinking the postpartum visit was irrelevant. And I think it's because everyone says it's too late. I already sucked it up, got through it. And, it's kind of like I'm at the end of the battle. So I think the relevance is just, we already got through a lot of the hard part. And now this is kind of inconvenient. And also just hearing a lot of the sense of just being rejected or left behind after they receive such intensive prenatal care. And then feeling really quite abandoned by their providers in their time of need. So now you want me to come back 6 to 8 weeks. I'm too busy. I've gone back to work. So just that has come up in like absolutely every circle. There's also a real wish for more comprehensive information about postpartum. And also anticipatory guidance on thinking about social support and self-care. We got great feedback on the tools that we're sharing. And I feel like some of those are still not, we keep iterating. We finally stopped iterating, I think a few months ago, because all of those tools are going to be available in North Carolina through our warehouse for free to all of the clinics. But lots of iterating on all of the words. And then also they said that they really wish that their providers knew more and could share more community resources. And also wish we had more community resources to share. But that was some of the things that emerged during those early groups. And these are just a couple of quotes. I could give quotes all day, but I thought these were really particularly attention getting. When I had my babies, no one had answers for me. I felt very alone. And so this, we sometimes just have heard that it can also, knowing where to ask for help can be really hard for folks. There were not any formal places for information about what to expect during recovery from a maternal near miss or near death event. I searched for help, but got no answers. Sadly, I was only given information because I knew what questions to initiate myself. And so these were from that early group, which is why we developed newmomhealth.com and saludmadre.com, because there was no information that you couldn't even Google anything. And then this is just a picture of the different resources we have, because I'm not going to talk about all of them. One that I wanted to call is birth control after baby. And I only have 2 booklets in Spanish that were printed, but it's online. All the stuff is online and you can access it. But that one is in its like 3rd iteration and has been really popular and might be something that pairs well with the work that you're doing on family planning. Because it's specifically written for new parents with concerns about lactation and some of the other unique concerns that they might have. And then this is just a screenshot from our website, which has information that, and I want to just talk a little bit about the design since you're curious about kind of sort of what emerged from our conversations. So we started, the first part is just about like the birthing person's body, her body, like what's happening. And we tried to provide information in a way that is reassuring. We try not to use something is normal. We try to say common, because women did not like the word normal, because it's like, if that doesn't happen to me, am I abnormal? And so we're like, oh, these are common things that happen. And so we really centered her well-being first. Then we have a section on infant care. And this is a question that we all have for you, is that we know that most moms are really focused on their baby. And it's really hard sometimes to get them to talk about their own needs. And so we put infant information there, but we wrote it in the context of mom. So it's not like you put everything to your infant, but here's what the infant needs and how do you address this in the context of your family and other things that are going on. And then we provide resources about kind of community and things that we don't talk about very much about, like going back to school or going back to work, because I think it's 1 in 4 women are going back to work at 10 days postpartum in this country because we don't have paid leave and they have to go back. I mean, I couldn't shower or really smell decent in the time that some people are going back to work. And so you have to have information about how to do that. And how are you going to, how could you advocate for yourself? And I will say that I had a colleague that worked in diversity and inclusion for McDonald's Global Corporation. And I hung out at her house and I tried to come up with ways that they could improve like their services. And it's complicated, but stupid because they should do that. Anyway, sidebar. It's not being recorded. It is being recorded. Sorry. McDonald's is great. So that's just a little bit about us. So our team has talked a lot about this meeting, and we were thinking about what did we hear the most across our research that we wanted to just kind of lead with. And just we hear so much that people say that they're not believed or that their postpartum concerns are brushed off. And this happens like front desk, this happens call center, this happens in so many encounters, and also, you know, it happens lots of our healthcare where people aren't believed. It becomes dangerous and even deadly when people aren't listened to when they're pregnant and postpartum. And also really a number one way to build trust with patients is to take their concerns seriously, ask them questions, follow their lead, and know they're the expert in their body about what doesn't feel right. And I just cannot underscore that enough. The CDC's Hear Her campaign, I'm sure you've heard of it. They have a whole campaign which is about you should listen to providers, emergency departments, so many stories. There's lots of intervention that we have in North Carolina, which is like little wristbands that say I've given birth that they put on so that if they go to that they, you know, someone would see that, yes, I've given birth, I should be treated differently as I'm coming into this emergency department. And yeah, we've heard of some pretty not great treatment from call centers and other nurses that are, no, sweetie, that's just the way it is kind of thing. We don't have any. So just wanting to really highlight that. And I think also because I'm a big fan of family medicine, the approach is also really important. And I feel like you all probably do this really well, but it's approaching kind of with gentleness at this particular period of time and with a genuine interest in her well-being. So I want to start, we've got a few categories that I kind of broke this down into. So the first one is I wanted to talk a little bit about anticipatory guidance. So I kind of started that conversation earlier, and I just want to reiterate that people just aren't prepared. And when they're not prepared, it feels really scary for people, and it just makes the experience more difficult. Women say they don't even know what questions to ask about postpartum, especially first-time parents. And that people who feel prepared for postpartum rate their providers higher, which I think is kind of important. And that providing resources about planning for postpartum might pair well with planning for labor and delivery. I think we have more to try to understand about the timing of anticipatory guidance in the prenatal period. And we are kind of hypothesizing maybe 32 weeks. Some of those later visits that are a little bit more frequent that you may not have as much to cover might be some really great opportunities. People can give out booklets. We've had people giving out information like the website and asking people to check it out, ask if they have questions. There are, I think, lots of different ways. We also have a postpartum planning guide that we have spent an incredible amount of time testing, retesting, and we don't have it in Spanish because when we took it to our partners, they just didn't even get the concept of not having social support. So we had to kind of reframe with how they look at support in their community. But we do have a postpartum plan that we have a piece that could be done with the provider with the patient. These could be done with home visitors or other supports, care managers that you might have as part of your team, or they could just at least be handed out. Said, here's something you might want to think about, which includes kind of them thinking even prospectively, what might be helpful? Do you have a dog? Would it be helpful for someone to walk your dog? Would it be helpful for someone to pick your kids up from school? And I think you can also start the underscoring the importance of asking for help is important and common, which is something that we see a lot of resistance to asking for help. And so I think if we can start to normalize that you're going to need help, and like, let's think about have them be directive in terms of what help they want, I think is can be really empowering. And I think this works. So Dr. Elizabeth Howell did this really great study that would, if any of you would like to replicate it, well, Dr. Bess and I talked about it. But so she did 15 minutes of anticipatory guidance. I think she did it at the 32-week visit. And these were the things that she talked about. Now, these, as you'll notice, many of these are not the maternal health warning signs, right? But this is what women are caring about, that they are very much report being caught off guard. I will say these were like, she read my list. And so just 15 minutes of anticipatory guidance and found reduced symptoms through 6-month postpartum of depression. And increases of duration of breastfeeding. You all have access to longitudinal data. So this could be something we could get an NIH grant and replicate at a larger scale. And I think based on all that we've heard with moms, I totally see why this is true. Because being afraid and being uncertain, I think has more of a toll than we think it does. So simple intervention. I know we talk a lot about care transitions, and I feel like Jan should be up here for this part, but our team finishing up a study, we call it our Patient Safety Learning Lab, and they have been video recording in the hospital about postpartum discharge and just kind of what happens in a room when someone's postpartum. So they've looked at how many times they're woken up, how they're spoken to, how they're given information at discharge. And what's kind of scary is that these providers know that they're being videoed. So we have big concerns about people that don't speak English, not getting good information. So it's like a fire hose of information. Here's this, here's this, here's this. Do you have questions? Great. And so I would suggest that you might want to just really think about what is the quality of information people are being given at discharge and how much can people handle. So some of the good things about data and video is that then sometimes hospitals are encouraged to maybe change some practices. So one of the things that we worked on with UNC is we've got this one pager, birthing parent health and infant health. And so we really distilled, and I don't know which version this is. We've really tried to distill down some really key messages to a one pager that hopefully everyone will at least get. And we, again, looked at the different for infant care and birthing parent care. And so we highlight kind of when to call for an emergency, when to call your provider, and then just general postpartum. And we're now currently working on little videos to go with each of these sections. We just recently have been talking to moms about this, and even this one pager can feel overwhelming to new parents. The feedback we're getting. We're like, well, okay, we're still going to give this to you. But we are working on a series of videos to kind of break it down. But I think if that helps you think about where the absorption of information is, and also how to assure that at least everybody gets something, this can be printed out with discharge. I would just offer you to think about that, and also be aware that probably all the things that you think are happening aren't happening, or they're just not even landing because your patients are so overwhelmed. It would be really awesome if people could get texts or calls from their providers. When I have my dogs come back from the vet and they had a shot, I get a call from the vet. So how's Daisy doing? I'm like, Daisy, it's fine. She's a dog. And you just gave her a shot. Like, thanks for calling. But we've definitely heard that not everybody has a reliable number that they can call. We've also heard lots of stories of women not knowing when to call, being afraid to call. And so some of really powerful stories we've heard are from Mahogany Mamas is one group in Greensboro that just really listening to them talk. And, you know, one woman said, you know, I had this really bad headache, and I was just gonna, it's been happening for a while, and I thought I was just gonna take a nap, but, you know, I texted my the leader of this group, and she got on the phone and she's like, don't take a nap. Let me get to your house. They took her in, and it was a really good thing. It saved her life. But she wasn't going to call the nurse's line because she didn't. And that's not just because of that, but a lot of people don't know, is this something I should call for? How will I be received? And so we found lots of stories of women kind of saving each other, or really encouraging them to get in if it wasn't urgent, but to get in to have something looked at. And so I think it's how do we normalize? It's okay to call us. Don't be afraid. I know with my kids, like we called all the time, the nurse line, like it's like every other day, it felt like nurse line, but you don't always necessarily have that even in that early postpartum period. So just something to think about. And again, I think this is where we're seeing people suffering because they're not knowing when to call. This is just like my putting on my brains on a slide, so don't even look at it. Last night, I was like, the 2-week visit. This is something I think is transformational, because I think that this is such a sensitive period of time in the life course for mother and baby. And so some of the things about this visit that our team wanted to kind of think about or share in terms of what might be important is affirm all the things she's doing well, because this is hard and she wants to keep this baby alive and do her best. And the narratives out there about what it means to be a good mother, like they are everywhere. And a provider with a simple wrong look at her can crush her. And this just crush. You have just no idea like what you hold in your hands. You probably do because you're awesome. But so really affirm what she's doing well, and affirm that this is a really hard period of time. And again, everybody needs help during this time. Really important. We think it's really important to be listening for birth trauma, and even I know that feels scary, but even asking some about it, because if you can get some intervention early for birth trauma, it can be really, really helpful. And trauma, you may look at a medical record and think, oh my gosh, this person, had an emergency C-section. She's probably got trauma. May not. You don't always know what is causing trauma for someone. And so we just were thinking this is a really gentle and important time to be checking in on trauma for sure. And then really kind of letting her concerns lead. Because as you saw, some of the concerns that women are having may not be on your checklist for maternal health warning signs. And then the other thing is just maybe asking about other supports they might have. So do you have someone helping them with lactation? Do they have a postpartum doula? Because trying to be like in alignment with some of those other folks is good. And it also gives you all backup if you know that she has a doula, for example. So I'm going to show this video at the end because I do not want to stress out this team, but I will show it at the end what it is, because I love this video so much and it's part of our new line. But Allison Stubbe made a short video talking about postpartum hormones. I really want to show it. Am I going to really mess everything up? Okay. It's only 3 minutes. But I just wanted to show it because it's only a few minutes. I can't tell you how much work it was. But it gives you a feel for like the tone and the voice of what we are finding is good for working with new moms. And it's on our website. So while they're pulling that up, I'm gonna also talk about the next slide. So something else that is really important is to normalize the uncomfortable. So we had an entire 3-hour conversation with one group about incontinence because it is so embarrassing. And if people don't know that that's common, they're gonna, oh, the suffering is ridiculous. Hemorrhoid, people aren't talking about pain. And so it's really important we found that that you all bring up the things that are uncomfortable. And just be like, you know what, this is really common. And just make it easy for people and not like wait for them to disclose that, because the data show that there's, as you all know, incontinence, tons, sexual issues, really a lot, depression, really high. And so we could screen or we could just talk about it. All right, so this video is very short. This is our, so like I said, Allison Stubbe is one of the founding co-moms, and I guess let's push play.
Hi, I'm Allison Stubbe. I'm a company doctor at Boston. Let's talk about this one. I need to share a little bit about why moms feel so cranky and irritable about 2 to 3 days after. Turns out it's because of a hormone.
Right again, it's very short. Did you say Carolyn? They're not going to invite me back. Videos are a new thing though, because that's what we hear that everyone wants are videos. And so, okay, you got thumb up? Okay.
Hi, I'm Allison Stubbe. I'm a maternal fetal medicine doctor at UNC. Let's talk about postpartum hormones. I wanted to share a little bit about why moms feel so cranky and irritable about 2 to 3 days after birth. Turns out it's because of a hormone called progesterone. So with our periods, our progesterone levels go up and down, and that's part of why we feel a little cranky right before we get our periods. But that change with your cycles is like 0 to 10. During pregnancy, progesterone levels go up to 150. And in your brain, progesterone is turned into something called allopregnanolone. And allopregnanolone is basically like taking an anxiety medicine like Valium. It makes you feel calm and happy and a little bit better to cope with what's going on. And that's great while you're pregnant, but your baby's born, your placenta comes out, and those hormone levels crash back down to 0. And suddenly your brain is saying, where is my happy hormone? What is going on here? And that's why you're trying to figure out how to feed your baby and function with no sleep and how to manage a whole other person, not to mention recovering from birth. So what I want you to know is if you're feeling crummy, it's not because you're doing it wrong. It's because you're experiencing the biggest and fastest hormone change of your life. Know that you are not alone. You are not to blame. And with help, you will get better. Please also be gentle with yourself and ask for what you need, because you're worth it and you matter.
So we have a bunch of different providers doing these. The next one is about calling for help and some of the warning signs. Nope, that's it. The other videos are in development. But that's just an example of kind of an approach and a way of talking. And that's the kind of thing that we hear moms are excited about. So I already talked a little bit about normalizing the sensitive issues. Also wanted to just talk about depression screening. I thought your 35% was pretty great. That means that someone is trusting you to tell the truth. Because we have a lot of non-disclosure of depression, and moms talk all the time about how to game that tool. They know what to say and not to say. We've heard a lot about use the tool, but if you really want to know the answer, talk to them. There's a lot of fear that if their score is too high, that they're going to be taken away, have their baby taken away. And this comes from all moms, not, you'd think that there's some moms that are at higher risk and it does happen, but this is kind of pervasive, like in the water. And so we'll see on we follow social media all the time. And every now and then there will be a story where something happens and a mom got screened high and something bad happened to her. She got sent to, her baby was taken, she got sent somewhere. Those stories have like a 6-month shelf life on social. They just keep shared and shared and shared and shared on loop. And as much as we try to like go in and say something, it happens, right? So there's just a ton of fear. And so when you've got that trust, and can actually maybe suspect someone may not have totally answered that questionnaire, I think it's worth doing more, but it sounds like you're doing pretty well on that front. And then the other thing is assessing for pain. There's a paper in the journal I mentioned about pain management, but there's a lot of people that suffer in pain. So just 1 or 2 other slides, and then we just get to all my questions and I'm done. I wanted to do a side note around screening for social determinants of health, because this is like really the big thing these days. And I know it's becoming a quality measure in hospitals. And so it sounds great that we're asking about social determinants of health. However, Kristen Tully and colleagues did a really nice study about it. And I just took some of the visuals from their published paper and found that, first of all, when it's possible, offer everybody resources. It's kind of like some of the, don't wait for them to tell you they have incontinence, just like tell everybody about it. So whenever there are resources that are available to everyone, tell them about it. And also we're working in North Carolina. Jan and I were talking about, we have five Medicaid care plans now, and they all offer different resources, but how do we make sure everybody knows what those resources are and how to get them and feel comfortable accessing them? So that's kind of like, we don't need to screen for that. Those are available. We should help everyone get those. We've also heard if you screen for something that you can't help with, that's way worse than not asking them at all, because it takes a high degree of vulnerability to admit that you need something, because that could put you at risk for getting called. So again, back to this theme that we've heard over and over and over again. So if someone's disclosed a need with you, they've entrusted you with something special and you need to treat them with care. But if they disclose something and you can't do anything about it, that's a really big trust disruptor. And so just, we hate to be the wet blanket on this, but again, it's like good idea, thoughtful for how we approach it. And so there's some kind of good strategies. And we especially found if people don't speak a concordant language and you can't get an interpreter, just stop, because you can cause a lot of additional fear. So you all have a chance to go from postpartum visit to postpartum care, which is very exciting. And so there's lots of things that we want to learn with you, and also lots of things that we are excited to explore. So some things that we're kind of looking at in your data, or as you all are doing this work, are what kind of needs are you seeing expressed in the 2-week visit as compared to a later visit, which might really help think about, even from a messaging, what might we want to push out to very new parents versus people that are a little bit further postpartum. We're really curious how earlier care influences patient and provider satisfaction, because we've heard that some providers enjoy that 2-week visit more than the 6-week visit. And I think provider satisfaction really does matter. And your care and well-being really does matter. So how is that a place that feels good? And does it reduce depression, breastfeeding? And I think there's some abstracts that are out there. So also write those papers and publish them. And then how is this part of maybe creating a new series of visits? Like, how can we look at the prenatal care visits and think creatively about a longer arch of care? And then finally, with postpartum Medicaid expansion, and also, by the way, North Carolina House and Senate signed Medicaid expansion. I mean, This is amazing, but we have postpartum Medicaid extension already. It's been almost a year. And I think we're discovering the ins and outs of actually how to implement it. And I think that may be something we could talk about later with transitions of care. But it's a whole new day in terms of what could be reimbursed and what services are available. And now we can create a whole different arch of services that are available. What an exciting time that you could also get paid for. And so I think it'd be great to have more thinkers about what that looks like. And I do think there are a lot of people nationally really interested in that as a topic. More questions? I think I mentioned this earlier, but is dyadic care actually happening in your visits? Or are you trying to like kind of get attention away from baby? We're just kind of curious like how that is working. And then also how you're engaging other family members in the visit. So that kind of goes back to the other discussion question about asking about other supports. I think what we heard and what we haven't talked about is those other support people. Like what role is dad playing or close partner playing? We heard that those folks can play a huge role in getting people to care when they're in emergent situations, making sure they're controlling their pain, helping them sleep. And we kind of we haven't talked about them either because it's new mom, not new dad health. But I think that's something to be thinking about. How are you working with doulas, care coordinators, and community groups? And are you all giving consistent or conflicting information? And then also, what are you doing to serve people who experience miscarriage, loss, or have a baby in the NICU? You talked about that a little bit earlier, but these are some folks that need really extra attention. In our state, those folks all have access to postpartum Medicaid. If you've had a miscarriage, you've been pregnant, and you can have a whole year of coverage. But what are we doing to really support them? And I think sometimes, especially in cases where there's chronic condition that's not being managed, us not paying attention to these losses in their reproductive wellness is the opposite of reproductive justice. So this is just, again, our website. Also, we fussed at, none of us think that this is what we look like. But we also made the person who narrated it make us go back and look a little bit younger. So that's basically what I had to say. I wanted to just say one other line of research that I wanted to just bring to this group, and it's not postpartum. It's kind of interconception, but we've been also doing a lot of kind of like you saw we did with early fourth trimester with those PCORI listening. We've been doing that with women who identify as Black or Indigenous and have chronic conditions about their reproductive health. And what we have found is just as much, if not more, neglect of reproductive wellness and care for people with chronic conditions, and seeing a lot of miscarriage, loss, depression, stillbirth, and just there's a lot in that space. So with implicit, as you're thinking about people with chronic conditions and connections with care, for me, that feels like a really place where you could really be looking at influencing maternal mortality and morbidity. But getting upstream, I know Nargis and I have 2 projects together about how can family medicine be thinking about reproductive health and wellness for the people you serve with chronic conditions. So I'm just putting that down for phase 6. So that's it. Thank you. Yes, I don't want to touch anything.
Does anyone have any questions?
Wow, such an incredible talk. Holy smokes. I gotta think about each slide like for 10 minutes a piece. So someone said the slides would be available, which would be great. I was thinking a lot about this idea of, all right, you're at, what's the word, touching base about trauma right after the birth. I know when I was a resident at the turn of the century, we talked a lot about like having a birth review. And that was something that was taught to me by my mentors at the time, because a lot of times, even if Mario and all those folks who do all this amazing work at the delivery room, maybe sometimes you're just not able to be there, or in my space, like I'm never there for the delivery. So having that conversation about what that trauma, whatever it looked like for that person, was part of the birth review. that we were, maybe we got that from the doulas, I don't even remember. But I think that you'd be surprised what people say, because again, you read the chart and you say, oh gosh, this must have been so stressful. But sometimes people say, you know, the worst part of the whole thing was the IV. And you know, so you really kind of have to ask and not make assumptions about. And if you read a NSVD, blah, 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 ho-hum kind of delivery note, there still could be trauma in there to the person. So I think that was a really good point. There was all kind of good points. I didn't write them all down. But I think incorporating some of that into, you know, doesn't have to be part of the data set and the dot phrase and all that, but incorporating some of that conversation as opposed to the checklist we have, or in addition to the checklist. I think it's something I'm going to try and do better job of teaching.
Yeah, I think it's so important. I mean, my mother still tells me about the day I was born when she calls me on my birthday every year. I have it recorded like 3 times because, you know, neither of us are spring chickens, and she still remember, like, it's the stories that we carry with us, and having supports with how we interpret those and how we share those is really important. And yes, I'm a social worker, but that's not soft stuff, because that stays with us, and it's part of our journey. And with so many things with mental health challenges, like the sooner we can talk about those, then I think the sooner we can heal. And I do think that when we think about so much depression in this country, we need to start to tease apart what some of those are. And I do think some of that is birth trauma. And I think if it's, again, just with my identity, I think we need to be really thoughtful about where that's also trauma because of someone's race or other identity, and thinking about how do we have the skills to process that, or who else do we need to partner with to be able to process some of that for people.
I think we also need to look at the support person's perspective and as you review the birth, because there's a lot of times like dads have a birth trauma, like earlier you said somebody had a C-section, no big deal, but the dad had trauma during that time. And I recently heard that there's daddy doulas, which was a new concept to me. And I was like, wow, we're going to try to get that going. But again, whoever that support person is, we need to include them in some way or allow them to have a voice as well.
I mean, in my dream world with family medicine, because that's who we have as a provider that sees the whole family, if by any chance dad is also your patient, you know, maybe you might schedule a well visit for him or a check-in for him too. I just think about that whole family care.
Thank you so much for that. That was really, really fantastic. I'm really excited about all of these resources that you provided, and like, I'd love for us to be able to take them back. We're just talking about what we're going to do sort of as a postpartum packet type of information. I'm curious from a sort of practical standpoint, if you've had anything that's worked or that you've talked to birthing people or mothers about timing for these kind of conversations. I know you mentioned 32 weeks. Was that sort of to do all of this, or like,
no,
what have you found?
Yeah, I think it's kind of, I think that it needs to be more than just one conversation. So thinking about, and also different formats, because sometimes it can also feel really overwhelming. We have heard that the postpartum care plan can feel overwhelming because there's a lot to consider. In places people get stuck, including people on my team when they've been pregnant, we test this on everybody, is the childcare, who's going to take care of your baby. And so don't start with things that are hard. Start with things that might feel easy for them, which is, how do you want to tell people about your baby? Do you want to share pictures on Facebook? Who do you want to come over? So those are a little bit easier conversations. Going back to work and childcare is people get really stuck. It's also thinking about who are else people in the ecosystem that could have some of this conversation. I think I'm preaching to home visitors as much as I can. I think home visitors have a great place if they're doing prenatal care to have those conversations. There may be other people on your team. In North Carolina, you know, some sites, at least we can get them to share the website. Like, that's minimum, but it's a start. And in some cases it might be, well, maybe give them a booklet and say, when you come back to your next visit, we could talk about this. And so there may be just and then the new thing with the postpartum plan is we have identified things that would be good for a provider to talk to somebody about. So that's a place where, again, we need to keep learning and listening, but also how does that fit into your natural flow of care? Because it needs to also feel like this feels like a good time to introduce this. And so, yes, I think it's that, but having it, I think childbirth education, if people are getting that, that's another really good opportunity. Having things in your office around, just kind of the idea that there's more that's happening than just the big event of giving birth.
I was just going to put a plug for prenatal group visits, like centering. It's just such a nice way to spend time, not only with the moms, but their support people. And you do it over time, over several hours. And we get so much more rich of information and follow up and support that it's not just that individual. Here's all your paperwork in 5 minutes. Bye-bye.
They don't, and we've had it and even with centering, it's a matter of, are you talking about what happens afterwards? So I think it's still, we all have to be thinking with prenatal care about, is this group model actually talking about that or not? And then I think the other thing we've heard is just that very precious first couple of weeks, feeling really connected to them, especially like you said, since they felt so connected to you. That's what we've heard a lot of too. The one pagers have been, I think, one of the most popular items in North Carolina. That seems to be the one thing that people feel like they can do, are the one pagers, for what it's worth. That's been really popular.
Any other questions?
Call me to collaborate. All right.
These research, there's provider resources on newmounthealth.com. Are these the ones that are?
So I'm going to let the virtual participants know that our next session is going to be all breakout groups. So you are welcome to sign out if you want.
Wants to join virtually like a group, I'm happy to put the Zoom up. Anybody.
Thank you guys very much for all that you're doing. Take care.
Thank you. Awesome. Thank you. Providers can use in practice. It's provider, and it's all there. Thank you. I don't know.